gosh, Tuesday, the 8th of April. Time is ticking away on us. We're already in second quarter. We just passed National Kidney Month, and I believe we're now in National, what is it, Kidney Donor Month. So the initiative continues to help those that are suffering from chronic kidney disease, and especially those that are in the latter stages of chronic kidney disease in seek of uh, a suitable modality, a suitable treatment for them. I think all of us want our kidneys to stay working and last with us for a lifetime. So quite often we forget, especially in the industry that I'm in, the dialysis industry, that we're hoping for a bridge. In the case that somebody ends up on dialysis, we're hoping for a bridge to something called transplant. And again, in the month of April, we'll be observing, I believe it's Living Donor Month. So I'll get back to you all on that. But in the spirit of the musings that we typically have here, even when we focus on things that are not healthcare related, we always look for stories of people that really care about what they do, really care about people, really have that personal personal touch to whether it be business to services to products to just a mindset. And I've been lucky enough over the past years to meet a lot of really interesting people, passionate people, whether it be on the professional side or on those that are receiving services and products. A lot of times that tends to be on healthcare. And when I meet these people, I quite often wonder, like, why did you start your journey in healthcare? I was lucky enough to meet our next guest, Lilian Okon. Lilian, you're going to have to help me
Okonkwo.
with Okonkwo.
Okonkwo. Yes.
Okonkwo. About, I want to say about a year ago. And we were at a conference called the American Society of Nephrology. And this was a very academic, large nephrology-based conference with the professionals from all over the world. And there were a few people walking around that I just felt this energy. And, eventually I got to sit down at dinner with Lillian and a couple other great people that they were vibing. I mean, I felt it from a distance. So what I know about Lillian is, she's well respected in the nephrology field, first of all. Second thing I know, and they said this, you guys are meeting her with me. All right, we got a little bit of feedback here. Where's the feedback coming? One second, guys.
Sure.
All right, how's that? Got a couple people with us, and I'm hoping that dialing this down a little bit will reduce the feedback. So, as I was saying, an expert and well respected in the nephrology field. But second thing, after having a chance to sit down at dinner, as well as a few phone calls and conversations, and also just the grapevine, right? The industry is very small. Finding out that this person actually cares. There's the heart factor is there. There's a very genuine, authentic care for the best in people that she comes across, whether it be on the collegial side or as a provider of healthcare, as a nurse practitioner, into the patients that she's working with. So I want to welcome to the podcast Lilian Okonkwo. Let me bring her over, guys. Then I'll fix up my screen. Hi, Lilian.
Hi,
Welcome to Musings
everyone.
with Morales.
Thank you.
So you
Oh,
have
wow. All that for
yeah,
me.
a few fans, a few fans. Lillian, where are you joining us from?
Today, currently from New Jersey,
New
so
Jersey.
northern New Jersey, so just a stunt throw from New York, but um, happy to be here.
Happy to have you here. So
Yes.
let's get the cliff notes down really quickly. You're a doctorate in nurse practitioning, is that correct?
No, no, I have my master's
Your
as a
master's
nurse practitioner.
as a nurse
Yes,
practitioner.
that is
I
correct.
think we were
Yes.
joking earlier about DND. So
Yes, yes,
we'll get to
yes.
that
That is
later.
it. Yes, yes, absolutely.
But I know
Yeah.
you have other titles. Besides the nurse practitioner, what else can we add to these cliff notes about Lillian?
Well, I like to say that I am a mom first, right? I'm a mom of two beautiful boys that I really, really enjoying. Um, I'm an entrepreneur. I'm a nurse practitioner. I've been in dialysis in the kidney world since John was a boy. I think if I start to talk about it, then I start to date myself.
No,
And I
no.
don't want to do that
All right.
just yet.
Enough time to know what you're doing.
I'm sorry?
Enough time to know what you're doing, though.
Well, a little bit. And then recently, I've had the opportunity to be my mom's child. It's been a very humbling experience. I think one that has also led me to see healthcare from the perspective of a patient.
Mhm.
Um, but all of that, um, I think, has just been very humbling, and I'm, just grateful to have had all of this experience, both from um, the corporate side of things and from the clinical perspective, because I think all of that just empowered me in the process of my journey with my mom.
Yeah. So,
Yeah.
as I was working with, hi Richard, I was working with Melissa from our team. She says, who are you working with tonight? Who are you going to get to know tonight? And I said, well, a thought leader. But what else could I say with the limited interactions we had? I said, I know she's a nurse practitioner. I know she's a healthcare leader. I know she's an entrepreneur. I know she's a wife and a mother. And then I also said a daughter. And because in our recent conversations, you've made it very clear that that's one of the more um, that's got a lot of your focus in latter days. Can you
Yes.
tell us a little bit about those titles and why that's actually kind of standing out to me so much?
Yes. So I'll start out with my latter titles as a daughter. Soon after I met you last year, or not long after I met you last year, um, I'd walked into my mom. I'd visited my mom in Maryland, and um, for some reason, she wasn't looking the way I would normally see my mom. My mom has always been someone who I revered. She's very hardworking, um, very playful. She's full of life, and she still was all of those things. She just looked a little bit different.
Mm,
And I looked at her and said, "Mom, you know what? I think I'm gonna. We have to get. We have to have you go see a physician." And she just said to me, "I've been to my physician all this time. There's nothing wrong with me. I think I'm just getting old." And I said to her, "Mom, I think this has got to be just more than you're getting old." I mean, this woman ran a business. She came in as an immigrant. She ran her own business, did very well. She just was looking very different. And I could not place my hands on it. So I said to her, "Mom, you know what? I think we should use the emergency room." And she pushed back. And somehow I sort of tricked her and said we were going to go to the grocery store. And that always seems to pique her interest.
oh yeah.
And we got into her car and I drove her past the grocery store, to which I didn't hear the last of it until we got into the ER. And while we were at the ER, um, I called the nurse to the side. And typically when I go into the ER, I never let people know that I'm in medical world, or
Mm,
I know anything about medicine, because I really honestly want to always see how people are going to be treated. Anyway, um, went into the ER, uh, and for some reason, all of the X-rays were done. Nothing came back. Blood work was done on her. Everything came back okay. And so I called the physician and I said, my mom looks different and I can't put my hands on it. And I was very honest with him. I said, she looks physically different. I can't put my hands on it, but please, can you take a closer look at her? Um, just to make sure that we're okay. I don't live very close to her. She lives in Maryland. I live in the New York area. It's about a 4 hour drive. I just need to know that when I leave her, she's going to be okay. And at that point was when he decided to order a CAT scan. And when the CAT scan results came in, actually, that was the same day. Um, and I don't know if I should bring this up as a as an earmark, but that was the same day Trump was shot in his
Oh,
ear.
wow.
That day, yeah. And I remember sitting in the emergency room with her, and he came back in. And instead of just giving us the news, he sort of was just quiet and he was watching the news. And he did that for about a whole minute. And I went, Doc, is everything okay? Are the results back? My mom is getting very antsy and she wants to go home. And at that point was when he said, I think your mom has malignant cancer. Um, And I said, What? And for some reason, every time it has to do with family, right? Everything you know about medicine kind of goes through your head, and all you're seeing are all you
Mm,
see are birds and butterflies, and nothing makes sense anymore. And a piece of me thought he didn't read the CAT scan properly, and then I wanted to pull out the medical card, right, and say, no, seriously, look at her. I don't think I don't think it's cancer. Maybe it's
mm,
something else.
mm,
And he went, no, Lilian, your mom has stage 3, stage 4. They couldn't place it at that point, and she's got cancer. And I felt like the whole world came crashing down that day. And for a minute, I could not find my footing. I remember going outside. It was a summer afternoon, and I was crying. And then I'll stop, and then I'll cry again and ask God why. Um, and um, and he said, you need to follow up with your physician outside. And my mom that my mom will need to follow up with her physician outside. And so at that time, I wasn't sure if I should hide it from my mom or if I should explain to her the extent of what we were dealing with. And so I just took it upon myself at that moment to come back into the room and tell her what I just heard. And the physician came back with me, um, but I don't think she understood the gravity of what she was dealing with or what she was getting ready to deal with.
mm,
And so, she picked up the phone, she called my dad. She was very lackadaisy about it. And I think everything I knew about medicine came in and out of my head. I thought about the worst things that can happen. And he said, look, he said to me, you're between the devil and the dark blue sea. And that part my mom understood for some reason,
mhm,
right?
mhm,
And you just have to make a choice on what you want to do. If you choose to do nothing, well, your mom only has 3 months to live. And or you can choose to take treatment and see where that leads you to. And so I turned to my mom, and the only thing that I remember coming out of my mouth was, Mom, we're definitely not facing the devil. How about that? We're going to jump into that deep blue sea and we're going to swim, swim, swim until it gets us to where it gets us to.
mm,
And that was the beginning of a long, tedious journey as a daughter, fighting alongside with my mom on the cancer battle that I wish to never see again, because I thought about everything that could have happened that did happen.
yeah.
um, and just as I was saying with you, I remember speaking with you, and I said sometimes I think about even the opportunities that came my way, um, the corporate opportunities that came my way, or the job opportunities that came my way, and that I had to turn away. And sometimes I'm not sure if I heard about that or not, but then I don't think I'll place my mom um, behind any of those opportunities. I feel that I still made the right decision by standing by her and fighting with her. Thankfully, I'm going to be transitioning her back. um, to her primary care. We're almost free, I think. I
with
think, knock on wood.
with dad
Um,
again,
so,
right? Back home with
yeah,
dad.
yes, back home with that.
Yeah.
That can't wait to get her back. Um, she's become the mom of the house, and so we're all going to miss her.
Mm.
Um, and but it's time for me to get back to what I love best, nephrology, right?
I'm sure she loves being with your dad best as well. So
I'm sure she does.
yeah, I'm gonna ask my wife that. How's she gonna feel about that? But tell me. I always think about gosh, the older I get, the more people I meet that don't have mom and dad around anymore, and you've got two parents. So it makes me kind of think about you're this successful healthcare executive provider. How'd you get there? Like, where were you born? Where'd you grow up? What was
Yes.
life like with mom and dad? What were the examples that they gave you that led to this beautiful person that we all see today?
Yeah. So I was born and bred in Nigeria. Went to school there. Got a chance to go to a couple of boarding schools where I was raised by British nuns. Um, Came to America. I think initially I wanted to be a lawyer. I really, really wanted to be a lawyer.
Hmm.
I actually started school, my university education, and in my second year, first semester, um, my dad made this very, very dubious decision um, for us to move from Nigeria to America. At that point, I fought him. I thought I was just being a rebellion, and I didn't know what to do because coming to America, becoming a lawyer was not something you could do as a first degree. And so it became, what would you do? Well, my parents are immigrants. I had to help them. And I thought about everything I could do. Um, and I said, you know what? I'll go become a nurse. Um, it was grudgingly initially, to be
Mm-hmm.
honest.
Mm-hmm.
But I remember my uncle saying to me, look, your parents are immigrants. You need to be able to help them at some point, at least with whatever first degree you have. And then if you want to go on to become a lawyer, you can go ahead and become a lawyer. I promise you, you can be anything you want to be in America, but you just need to be able to help your parents. And so I said, okay. And that's how I ended up going to school for nursing. I started out with my associates and got my associates, but ended up loving nursing so much. Actually, I got so good at it that I, I, I remember thinking to myself, how did I miss the fact that that I didn't want to do nursing? It showed me who I was. It brought me out. It brought my personality out as a person. It taught it taught me that I could endure the gruesome schedules of being a nurse.
Mm-hmm.
Um, and so I decided to pursue my BSN immediately. There was no need to waste any time. I pursued my BSN, and then figured at that point I'd started to go up in the corporate ladder, and I led nurses, led clinical teams, and I figured, you know what? Uh, while we're going up in the MBA School of Life, why don't I go in and become a nurse practitioner, honing into my craft, become a nurse
Mm-hmm.
practitioner, and be good at what I do. I figured I had the experience of being an executive. All I could do was make good on that while I went in and became a practitioner. And that's how I ended up being a practitioner.
Mm-hmm.
Um, and I have loved it so much. I think the difference is you get to see when from the corporate side of things, when you're when you take a challenge or you know you need to reach a patient, you're not just reaching one patient, you're reaching multitudes of patients. and then you get to see what that impact looks like for me on the clinical side of things. And so that's where I've sort of built my career on, where I can bring the clinical and operational piece to the table, supporting it clinically as well. And if I forgot to say this, while I was in nursing school, I was actually a dialysis technician as well.
Really?
And so that's
I
yes.
didn't know that.
So oh my goodness, I can break down the Fresenius machine, a Bebron machine, you name it, a Baxter machine. What other machine? There was one more. There's one more that I used
Nice.
during when we did acute.
Hmm.
So it's Bebron, Baxter, Fresenius. It's one more, and I had experience with all of them, and I think all of that sort of made me who I was or who I've become today, because there's no way becoming a nurse, I got exposed to home hemodialysis, I got
Hmm.
exposed to peritoneal dialysis, um, hemodialysis came in naturally. Um, and then I started programs where we would go to physician offices and we would get patients where we would explain to patients. It was a group of us at that time. Um, when I worked, they're no long. I think they got bought up by DeVita, but it was renal dialysis, renal physician dialysis. Give me a minute, I'll remember. But it was a group of us. So it would be the nurse, the dietitian, the social worker, and we would get together and go to physician offices and create classes where we wanted to capture CKD4 and 5 patients
Got it.
and
Okay.
educate them on what dialysis was about, or even give them treatment modalities, right?
Yeah. Yeah.
Um, on the options that they had. And very readily, you saw people who understood home because I was able to talk about home, and I was sometimes able to bring the machines and show it to them and have them feel it, touch it. There's something to be said about when people can actually see what it is that you're talking about versus um, when it's just on the screen, right?
Agreed. Yeah.
But when you see it and you touch it, you feel it, the dexterity. They feel that dexterity. At that point, they're willing to listen to any other thing that you want to tell them. They're willing to listen to the fact that they can have this much amount of water, or they listen to they're able to listen to the fact that, look, your insurance covers this, it doesn't cover that. You just have to get their attention that very first time and have them understand or tailor your teachings to what it is that they're looking to understand at that point. And um, that was interesting for me as well too. And
Yeah.
so
I think
me
that's
having all
really
of that experience has just accumulated to now.
so. So you were nursing student, dialysis tech. Did you go right into dialysis roles as a nurse? Is that
Oh,
kind of where you've
yes,
grown up in
absolutely.
dialysis? Everything.
Absolutely. Yes, yes, yes. For a split second, I thought I was going to be an emergency care nurse. I think I was trying to do the McDreamy thing. That went by really fast because
Yeah, I
that
heard
went by
some
really,
interesting
really
jokes
fast.
along those
And
lines this week.
yeah, no, 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 that went by really fast. And
How'd you become a dialysis tech? How was that introduced to you?
that's interesting. So let's see. While I was trying to get into nursing school, um, I was actually a transporter
Okay.
in a hospital.
Mm-hmm.
At this time was when I was still battling with my parents about having to go to nursing school. How did I get from going from law
Law
school
school
into
to
nursing
nursing.
school? and
Yeah.
and so well, I had to still get a job because I had to still help my parents. And
Mm-hmm.
so I got into the hospital as a transporter, and I was transporting a patient. And every time I would transport patients down to this basement where the dialysis place was located, right? And the nurse would turn around and look at me. I was
You
always
might have
impeccably.
just dated yourself, by the way, with the basement. I want to hear about that. I'm sorry, you might have just dated yourself.
I
Hopefully,
was
there's
always
none like that anymore. Next door to what?
in the basement. No, no, I think we've graduated. We're now on the first floor, or
Yeah.
sometimes even the second floor. So, but yes, yes. When I say basement, I think yes. I just dated myself.
Yeah.
Yes, you're absolutely.
Sorry, Lilian. I have to call you.
Oh goodness. Okay. So I was always impeccably dressed, and she would say to me, "How are you not a dialysis technician?" And I said to her, I don't know what that means, because everybody at that time seemed to always go for being a PCT, right,
Hmm.
while you were in
Hmm.
nursing school. And I thought that was the right way to go. And she said, you should try dialysis. Um, and I said, sure, why not? And she introduced me to an outpatient guy. His name was Tony. I went for the interview. And then he said, you know, your starting time is going to be at 5 a.m. And I was like, absolutely not, because it was 40 minutes away from my house. It was a DaVita clinic. And when he said 40 minutes, which meant I had to leave my house extra early to
Yeah.
get to work.
Yep.
Um, but then as soon as I said absolutely not, I went, you know what? I'll take it. I'll take it. And that was at the time, again, I'm about to date myself. And this was when we were using reuse dialyzers, right?
Done. Done. Now I know.
The
I remember that. Yeah, I remember it.
right. And so you had to come in extra early because you needed to rinse the dialyzers to use them, make sure you
Hmm.
got the right dialyzer for the right patient,
Hmm.
and all of that.
Yep.
And so I took it. It was in Rockville, Maryland at that time. That was my first stint with dialysis. Um, Davida ended up training me, and I enjoyed the training so much. I think it set me up again for my whole career in dialysis. Um, and then I started working in dialysis. I saw all manner of people, black, white, brown, you name
Yeah.
it.
Yeah.
People who had
Doesn't
different
discriminate.
statuses. Right,
Kidney failure
right,
does not discriminate at all.
right. Different statuses in life. And um, initially I thought, did they do something? Did they live a rough life?
Mm.
Like, how did they end up on dialysis? And very quickly, I just found out that it didn't discriminate, right? It didn't.
Right.
It wasn't about how you lived. It wasn't about what you did. Um, because even I remember treating a very very young girl who was probably my age, and she had lupus.
Hmm.
And I remember treating her, and treated her for about a year. Got to know her very well, became a very good friend. I looked forward to treating her whenever I walked on that day. And one morning, I came in and her chair was empty. And
Mm.
so, we went around trying to call her, trying to make sure that she was okay, and to see if we could reschedule her. And she never showed up till today. Very pretty girl. Um, and she died and left a daughter. Um, and at that point was when you start to really, I started to realize that this just wasn't dialysis. This wasn't just what I was doing. It was actually affecting people's lives. And if they didn't get it, if they got it and they didn't get it well, maybe would not show up the next day. And again, very, very humbling. And I started to change my whole perspective on healthcare, on even nephrology in general. And obviously, when I finished nursing school, and I did that very sweet stint in the ER, I just said to myself, I've got to go back into nephrology. It's what makes sense for me. It made sense for me.
Call of the
And
wild, huh?
yes,
Yeah. Yeah. You
yes,
can't. You can't.
yes.
Can't
You
fight it.
either really like it or you don't.
Yeah.
Yeah.
I agree with that. I need to call out two things that I picked up here is one, you mentioned that the training that you got as a hemodialysis technician set you up for this wonderful career and this wonderful contribution to people who really need people like you.
Yeah.
Um, Two, you said that a lot of people at the time gravitated towards a PCT, which I got to call it out. I know one of the people that's probably with us right now um, would kill me if I didn't like highlight this, that you have a clear differentiation between a PCT and a dialysis technician. Is that right?
Yes,
Can you tell
yes,
me a
yes.
little bit about that?
So PCT is a PCT, with
Mm,
all due respect.
mm-hmm,
And you're working the med surg floor, and you still get to see all arrays of patients, but it's not specialized,
mm,
right? It's the med surg, you're seeing all patients, general care, whereas a dialysis technician is, you still get to take care of a patient, you still get to see a patient,
yeah,
but now you're specialized and you're taking care of a patient's kidney. So completely different way of thinking. Um, I think even to an extent, I want to say that a dialysis patient actually trusts you to take care of them,
mm,
because any mistake you make can put that patient's life at risk. And so you have to become very good at your skill. Um, and just that alone makes you different than a PCT, if you ask me.
yeah. I agree. Specialist is king there, I think, and
Yes.
you know, you mentioned like the contribution that you give to an individual and the trust that occurs between a patient and their hemodialysis technician, or really their entire hemodialysis team, because it's
Yes.
so frequent. But
Yes.
the time plus frequency that a hemodialysis technician or a dialysis tech spends with the people that they care for, it you know, just the story of you seeing mom and she just looked a little bit different. Like this is the type of observation that I've grown to expect of hemodialysis technicians, because you see your patients so often. If they didn't comb their hair today, you should notice. You know,
Right.
if they're a little
Right.
pale, you should notice. If they got a distended jugular or if they've been biting their nails, like you should notice this stuff, right?
You'll notice.
That's
Yes.
how close we
Yes.
are. So, you know, I'm
Yes.
curious that being a hemodialysis technician, um, did that mold, did that contribute to your ability, your observation as a registered nurse, as a healthcare leader? Do you feel like it added value in starting as a hemodialysis technician?
Let me rephrase your question. If you're asking, if my experience as a hemodialysis technician enhanced my assessment skills,
Yes.
absolutely.
Yeah.
Because, like you rightly said, you see a patient every single day. One of the benefits of seeing a patient every day is, you know, the patient. You can
Mm,
almost close your eyes and be able to tell a patient when you know, when you touch patient. However, it's the slightest changes in a
yeah.
patient that makes or breaks or saves a patient. Because you see them so frequently, sometimes your eyes may not even catch those very little changes,
Yeah.
those very subtle changes. Um, so yes, absolutely, absolutely. Because sometimes it's even the most minute things. A patient comes in, they hide edema very well, and then all of a sudden you can see it around their
Periorbital.
periorbital
Yeah.
area, and you're like, something looks different about you today.
Yep.
Um, and all of a sudden they're carrying more fluid than they would normally carry on on a on a dialysis day. Um, so yes, absolutely, it definitely enhanced my assessment skills, if I have to say so myself, um,
Yeah.
because you can easily miss the mark on a hemodialysis patients, because again you see them every day or every other day, depending on um, where you see them. If it's home and you get to see them every day, if it's hemo, then it's every other day.
Hmm.
Home, you see them every day while you're training them. Hemo, every other day, right?
Yeah.
It's at least 3 times a week.
Yeah.
Yeah,
So, Lillian, you touched on an experience that you had interdisciplinary where you would do the pre ESRD or even transitional type of ESRD from
yeah,
4 to 5 type of education.
yeah,
Um, you know, can you speak a little to, well, I guess kind of two thoughts here. We have a severe shortage of registered nurses in the United States right now. And with that, delivery of treatment type of care becomes difficult. I mean, you can go to most dialysis centers and find some sort of staffing capacity issue. With that, there's also shortages of hemodialysis technicians, and I can't help but notice that you had this transition from dialysis technician into registered nurse. So it's a big step to become a nurse. I mean, even your family said, "Hey, what do lawyer to nurse, right?" The move to dialysis technician was maybe a dip of the toes in the water,
right.
and you got to see all of these comorbidities, all of these specialists come together for the sake of a single person and their unique condition. Would you say that whether it be dialysis technicians in the dialysis industry or certified nurses assistant patient care technicians in the skilled nursing facilities and the hospitals, would you encourage people to dip their toes, or would you encourage to jump all in? I don't
You
know if
mean into
that's,
dialysis?
well, I'd say into nursing. I mean, I feel like, that I'm going to be biased here. I feel like that
Yeah,
step into healthcare, especially dialysis, because we see so much,
yeah,
is a great way for somebody who says, I want to be in healthcare, but I don't know what. And quite often, the road ends, or I should say, the road always points to be a nurse. But there are a lot of other things that one could do. I know I've went through that dilemma many times in my life where it's like, Morales, go be a nurse, because if you want to do this, you got to be a nurse. I never did it.
yeah,
I
yeah.
don't feel that I made the wrong decision. I have talents that have led me in other areas, including teaching, which I know we planned on talking about tonight, and
Yes.
raising dialysis technicians who I love to hear stories like yours, because this is, you ever play Super Mario Brothers? You remember that video game, the little Luigi
Yes.
and Mario?
Superman. Yes,
Yeah,
yes, yes,
so
yes.
they eat a flower, right? And then little Mario becomes
Bigger.
big Mario, and then eventually they throw fireballs or something like this, right? They're on fire or something like that, and
Yeah,
they can run over holes and all this kind of stuff, run through the
yeah.
bad guys, right? I kind of feel like, you know, going through dialysis training is that power up. It gives you the ability to be exposed, to participate, to contribute, and to grow into that fireball Mario of whether it's a registered nurse.
Yes.
I've taught people in the past who have become also nurse practitioners in the progress of things, social workers, dietitians, physician assistants. But the first dip in the toe was something like a CNA, an MA, CHT, something along those lines. So, would you encourage people to take those sort of steps of just dipping the toes in, finding something for exposure, and then finding out what's next?
I think if your passion is healthcare, something knowing about healthcare I mean, always gives you a leg up, right?
Mm,
Um, Direct patient care, you have to have the passion for it,
yeah,
because they're just days that you won't have the feeling to move forward. And there are days that are just going to be hard. But what
Hmm.
keeps you going is your passion,
Yeah.
right? Your passion lets you keep one foot in front of the other. Um, so for healthcare, I'll say this: direct patient care isn't for everyone,
Agreed.
right?
Agreed.
But the business of healthcare, you should at least know the basics,
Yeah.
or what makes up that piece of healthcare where you are in. Because if you're talking about renal care, for example, you want to know, you don't have to do it, but you want to know what makes up that business, right?
Yeah.
For you to be able to talk about it fluently. Direct patient care, I'm just going to say, leave it for those who have the passion. In terms of the shortage of nursing care, I wish we didn't have the shortages that you're talking about. Unfortunately, I feel like it's now becoming even a worldwide situation. I recently was just in London, and um, even the UK is having a shortage of nurses to the point where they're having to cut down a lot of administrative um, work to put that money back towards healthcare workers, just
Yeah.
so that there's some sort of um, there's some sort of people, so that people want to come in to
Hmm.
work for health, as a healthcare worker, because they're done in bringing people in from different countries. They want to invest in the ones that they have. So the shortages we see um, is everywhere. Sometimes what I don't understand is nursing school, I have to tell you, was not easy. Even though I was very good at it, I had
Hmm.
to read my butt off, right?
Yep.
Um, and so sometimes I wonder why we're not cracking out enough nurses or even physicians,
Yeah.
right?
Yeah.
As fast as we are going to need them come 2030,
We can't even
right?
fill up the nephrology fellowships, right?
No,
Yeah.
no one is taking it.
Yep.
No one is taking it.
Yep.
Um, and hospitals are now having to become very creative in how they utilize even nurse practitioners to be able to see patients,
Right.
nephrology patients, because sometimes in a whole hospital, you only have about 4 or 5 nephrologists, and that's not enough, you know? And so they're having to work with nurse practitioners to be able to expand the reach of patients that they see. And we
Yeah.
already know what the number of nephrology patients are going to be.
Yeah.
Very, the last time I checked, I think it was 1 in every 3 or 4 patients are walking around with some sort of CKD going on.
Mm.
Um, we have a high amount of comorbids that put,
Yep.
again, a lot of patients
Put you in line.
at,
Yeah.
right, that puts you in line
Yeah.
for having some sort of CKD.
Yeah.
And so I think the question is, why are we making it hard? Right?
I don't disagree with you. I'm curious your thoughts on if we're gonna crank out more nurses, more doctors, more dialysis technicians, more whatever it
Mm-hmm.
is.
Mm-hmm.
Um, do we have the people to teach them?
Mm.
Is that part of the problem?
And that's another part of healthcare that I think that is, easily overlooked, because I'm a nurse today. I'm a nurse practitioner today because somebody taught me to be so, and somebody gave me the opportunity to become one. And so,
Hmm.
yes, absolutely. Again, if you had to become a dialysis teacher, if you had to become someone who is teaching direct patient care, even you yourself have to know what it is that you're talking about. And
That's
so,
right.
to answer your previous question about should everyone dip their foot into healthcare, you have to know the business. You have to know your audience. what it is that you're, if it's direct patient care, absolutely you can't teach somebody what you don't know.
Right.
If it's on the business side of things, you can't talk about the business if you don't know the basics of
Yeah.
what it is that you're talking about. So
Yep.
I think, again, to answer that question, if you're going to go into healthcare, especially renal care, and I'm going to be again biased on this, know the business, know
Right.
the basics,
Yeah.
um, so that when you come to the table, people listen to you, and people know that you at least have an idea of what it is that you're talking about,
Hmm.
or you start putting a business plan together, or
How old are your children, Lillian?
oh God, I have 14 and I have seven. I initially said I was going to have one and then changed my mind. And 7 years later, I had another one.
I know that
Um,
story too. My youngest is like 10 years from the
yes.
last one. So what do
Yes.
they want to do when they grow up? What's their
So
goal?
my oldest is a very cerebral person. I think between chess games,
Mm,
uh, coding, I think I'm going to end up with an engineer
okay.
or some sort of engineer. I just don't know yet. So we are putting him on that path and making sure that it's clear. It's very clear. His, I don't feel like I'm going to have a physician in him or a medical student in him. I think that's just
Hmm.
gone down the drain. The second one, I'm still trying to figure it out, honestly, because
Hmm.
between him testing the Jesus in me and um, trying to constantly weasel his way out of anything and everything, I'm still trying to figure out. Maybe he just may become the lawyer. Sorry, lawyers,
Yeah.
but he just may become the lawyer because he's always trying to weasel his way
Maybe he's very
out of
efficient and
anything.
he'll develop some
Yeah.
sort of process that says, why do you do it that way? Right. Like, so the reason
Yes.
I ask is, I have four kids, Lillian, and
Yeah.
they do what they're supposed to do. Like three of them are
Yes.
adults, and they kind of do. Yeah, my oldest, she's an LVN. She works in dialysis. She works in some concierge type of stuff as well, and
Nice.
she's got a little business mind. So I think she may have observed some of that in me. But she's 28. Like when I was 28, things are way different today than they were when I was 28. My
It's true.
oldest son, he's an entrepreneur. He does like koi ponds and takes care of really expensive fish and sources different sort of things for that industry. My youngest daughter, she's doing taxes, and my
Mhm.
youngest son, he says something. He's 11. He says something different every day. I mean, it was like he wanted to be a vet and he wanted to be a mechanical engineer, and he just told me something else the other day. But it was new. And in my years, like I said, I kind of somewhere along the line I heard like every 8 years you go through this drastic life change, and man, it's pretty on track for me. I've changed a lot. I've been in healthcare for 25 years. I grew up around it because I was exposed to somebody that was on hemodialysis as a child, and we took care of him at home, right?
Mhm.
But when we talk about this shortage of people to care for people, uh, I meet a lot of people who have chronic kidney disease and end stage renal disease, and it seems there's always a lot of family around them that would love to care for them,
Yeah.
and oftentimes want to help but don't know how.
Mhm.
And then they fall into these dialysis centers, and that can be daunting to really understand what you're in for there as well, right? And let me digress a little bit, just to regarding these shortages. What are your thoughts around introductions to healthcare in like rudimentary type of education, career and technical education programs in high schools, career pathways that are leading people towards, you want to be in marketing, you want to be in industrial work, you want to be in a welder and automotive, you want to be in healthcare, introducing things like certified nursing assistant
Vocational.
programs, vocational
Yes.
programs.
Yes.
But the one thing I've noticed over the years is, and I don't know if you know, I actually own a dialysis training business where we train techs and nurses. And we've taken this program to high schools and they go like, "What the hell is that?" They have no clue that this is a thing, that there are more than 500,000 people going to these dialysis centers, you know, 3 times a week, and that there's a whole workforce revolving around every one of those individuals to give them an interdisciplinary view, from
Yeah.
social workers, dietitians, nephrologists, nurses, biomedical technicians, hemodialysis technicians. Some of those are less known than others. And I would
Yeah.
say like hemodialysis technicians and hemodialysis biomedical technicians, nobody knows about it. So have you seen anything like this in your experience, specifically around nephrology, dialysis, that is taking the word, taking the good news of this industry, and that there's a lot of people needing help, and it could be you, into high schools, into junior highs, into ROP programs, things like this?
You know what? Unfortunately, no. And I'm
Yeah.
pretty close to grassroots to know. Now, I'll tell you this. Um, while I was in nursing school and I was a technician, I did see a young nurse, an LVN nurse, who came out of school, and she was then in Maryland. You had LVN nurses who could do quite a bit of things. Again, back
Mm-hmm.
in the days, right? So I'm
Mm-hmm.
dating myself again. And I used to be so astounded because I felt like I was suffering and going to nursing school, and while I was a tech, and here was someone who um, finished as an LVN. She almost felt like she had the easy way out.
Mm-hmm.
And so one of the days I just stopped and I asked her, I said, "How did you become an LVN?" And she said to me that it was introduced to her while she was in 10th grade or
Mm.
11th grade, if I'm not mistaken.
Yeah.
Um, while she was in high school, it wasn't specifically dialysis, it was just an LVN program. And so it just turned out to be that she came out of LVN school 12th grade. So at the end of 12th grade, she came out with an LVN degree and then came into
12th grade.
dialysis. And so, yes,
Wow, that's great.
yes. And I was just very impressed with that because at 12th grade, you're 18,
Yeah.
and she took the boards and she passed it. And here it was, over 18, struggling to go to school
Yeah.
while being a dialysis technician. I say this to say that I think, and again, don't I'm going to speak from experience, right? I think every child should have some sort of vocational work that they should be good at by the time they come out of high school.
Yeah.
Um, I'll tell you this,
That's
right?
powerful.
Um,
That's really
y-
powerful, actually, what you just said.
yeah, when I was in boarding school, as a senior, we were allowed to have our hair, and again, being that we were raised by nuns, as a junior student, we were not allowed to have lots of hair,
Mm.
and we're allowed to keep our hair short only because that was a way to make sure that we stayed clean and we made our hair. But as you became a senior, the nurse would say to you, you can grow your hair out, right? But you had to learn to do hair so that somebody else could do your hair. Well, fast forward to America. Um, guess the side gigs that ended up giving me some extra money while I was in nursing school, learning to do hair. I
Yeah.
braided hair
Yep.
and it gave me extra money. So I lent mine as a result of the fact that I needed to get my own hair done while I was in school. S- I needed to learn to do somebody's hair for somebody to learn how to do my hair. But in hindsight, maybe those were how the nuns incorporated the fact that we had to learn something vocational. It was an all girls school. And so we had to learn something vocational while we were in school.
Yeah.
But I do think that every high school student coming out should learn something vocational, because I think back to that young girl now, um, and I think about the future she will have. Think about it. If she never furthers her education, she may not be rich, but she will
Mm.
always put food on her table, at
Mm-hmm.
least comfortably,
Yeah.
right? Not everybody has the ability to go into college immediately, for whatever reason, right? Maybe because they're not ready, maybe they're still getting to come into their own, their own self, maybe for financial reasons, whatever it is. But if they have that vocational skill, it provides them the confidence to see what the world can look like and maybe even explore it further. So I say this to to say yes, I am an advocate for having kids have a vocational career. My kids, I will force them to plumb. And if not carpentry, like, look, there is going to be an array of it. You've got to choose one,
You got to pick
right?
something that'll help
Uh,
you at home. Yeah.
Yes, exactly. Exactly. This I'm not saying don't go to Harvard or MIT or whatever, right? Do
Yeah.
all of that. I want you to do all of that, but you're going to go in with a skill, um, that you have to do with your hands. I think it's very important. Um, with regards to having dialysis introduced in high school, unfortunately and sadly, I haven't seen very much of that,
Yeah.
and I think we need it.
Yeah. I agree.
Yeah,
It's an
we
initiative we've taken. There's a lot of programs out there, and in the last couple years, we actually figured out that there are programs existing. They're called career and technical education in high schools,
mhm,
and
mhm,
at least here in California, every district you'll find CTE programs, right? They're very specialized, like career track type of programs. I know I want to be in marketing and graphics, so okay, you can go do that, but they have to go through exposures to
mhm.
other industries as well. And I like, you saying like having a vocation that you could do right out of high school versus like the let me give it a year, a 2 year, figure out what I want to do while I do what, maybe nothing, right?
Yeah, yeah,
And a lot of people get stuck in that because they don't know what they want to do right out of high school. But if they did have something they could do, I think they would be in a much better state. And, I
right.
don't want to get too deep into the state of politics and, state of the nation, but there are a lot of people who graduate high school and they're in that situation that they haven't learned anything that they can actually go apply tomorrow. They need like much more school. They need a lot of on the job training. So I really love that suggestion that and the approach that was in the UK. You said right the school with the nuns.
Yes,
Yeah, I mean I really love that approach that you're gonna leave this school with a skill that can you can at least put food on the table. We have
yes,
we have a few people with us. I just want to say hi to Richard Vanderplas and Justin Pham, good friend of the podcast, also many time guest. Looks like Lorena or Lorraine, one of the students of Dialysis Education Services, is on, and she's throwing out that suggestion of going to high schools on career days, showing them videos of
yes,
dialysis techs, what they do. But I
yes.
got to
It's
agree with you.
actually
It's
a good
not for
idea.
everybody, right? This is a very social job. And, before we move on, I just want to tap on one other thing that I picked up in about 20 minutes ago. You called some of your patients, you called them your friends. And,
Yes.
that, hey, I don't care who's watching. Let's get into controversy here and find out, like, what do you think, guys? Are your patients your friends? And I'm going to give you
Mm-hmm,
my personal side of that. I can't
mm-hmm,
help it.
mm-hmm,
And I spend 12 hours a week at least with
mm-hmm,
these folks, and we
mm-hmm.
hear the good and the bad. And, we remember birthdays and we remember the names of their spouses and their children's, and,
Yeah,
that they're writing a book or that they got a garden that they're finishing. And,
yeah,
that observation like you had for mom, I think if we all, as whether we're a tech, a CNA, an RN, if we all treated people with that level of observation, they would know that we care. And and I just don't know how to. I just don't know how to turn that off. So can you talk about that a little bit? You said friends very explicitly here. Tell me what
Yes,
that means
yes,
to you.
yes. Um, we see if you get lucky and you get to work in a place for more than 1 year in a dialysis center, you get very, very close to them.
Yeah.
Even as a nurse practitioner, I currently practice with a huge nephrology, and I've always done this as a way to make sure that I never let uh, my feet off the floor on clinical care.
Mm,
I practice with Summit Health, right? And even though I did that once a week, or I do that once a week, on the days that I do show up, my patients are excited. They're happy. We get to talk about everything under the sun. Um, they get to be heard, right? And so, yes. And on the days they don't see me, some of them actually somehow get my personal number, and to text me
mm,
to ask me if I'm doing okay.
mm-hmm.
And so, yes,
Ask you if you're doing okay. That's interesting.
yes, yes,
Mm-hmm.
absolutely. Um, So I think to answer your question about being friendly and friends with patients, yes, I have become friends with some of my patients, and but for the most part, I am very friendly with a lot of my patients.
Mm-hmm.
In fact, with almost all my patients, because at the end of the day, they are human beings, right? They've got real lives. We've got real lives. We're not robots, all right? Um, the young girl I just told you was someone who I got to sit down with, and she told me, she shared what she wanted her future to look like, right?
Mm,
She shared her fears with me. Um, she was afraid that one day she was going to lose her life and she wasn't going to see her kid grow up. That ended up happening, right?
yeah.
She shared almost every single thing I can think about, down to when she thought she was a bit pregnant, when she thought she was pregnant, right? And can it get controversial? Absolutely.
Mm-hmm.
Absolutely. Um, and yes, we have to know when to draw the line with our patients. I do agree. It's just this one particular one. I just sat down and I got to know her. Um, and living life through even her own lenses,
Mm-hmm.
again, was just very humbling. And on the day she did not show up to that chair, all I could see was her daughter crying. I did not just see my patient, I saw a mom who wasn't going to be able to see her daughter graduate high school. Um, and she waited for a kidney so badly. She was on the transplant list. She did all the right things. Um, but she never got a chance to get that transplant. And yes, she did die. And so it's a very thin line you can walk. I get it. And for the most part, you want to keep a very professional line. But sometimes, because you do get to see the patients all the time, you do get very friendly with them. And sometimes they do turn into friends. The other day, I walked into a restaurant um, to have dinner with my friends, and I walked into one of my patients, right?
Mm-hmm.
And I wasn't sure how to react because he had his own patty right there.
Mm-hmm.
And I didn't want to say, hey, that's, like,
Yeah.
that, because I didn't
Then he's
know.
gonna have to explain who's this person, and
Right.
yep,
And so I just said, "Hello, Mr. XYZ, how are you doing?" And he went, "Long time I haven't seen you." And I went, "Yeah, I've just been taking care of my mom." And he's like, "Is your mom okay?" And so as he was talking to me, my husband comes in, his wife comes in, and I'm thinking, okay, how am I going to introduce? How do I introduce this person without me letting everyone know that he's a patient of
you guys were
mine?
both getting sweated probably at the same time. Like, hey, what's
Yes, yes. Yes. And I said to him, "This is my husband, and those are my kids." And he was like, and he went, "I've heard about you. I've heard about you. I've heard about you." Um, and then he turned to his wife and his party of friends that were with him on the dining table and said, "This is my nurse practitioner. She takes care of me." And I went, "Oh God, okay, all right."
safe,
That took that. That took
safe,
that.
yeah,
That took
yeah,
that. Right.
yeah,
But and if even if he did not introduce me as such, right, I would have been okay with it because again, you have to know where that line gets drawn, and not everybody wants their business known out there,
yeah.
right?
I
Um,
I I used to live in Long Beach, work in Long Beach, run the streets in Long Beach, and I'd see people that I cared for all over the place. And forgive me, but I had a friend years ago. Um, he was a dialysis patient, and he was a Chinese Malaysian guy.
yeah.
And I asked him. I said, "Hey, buddy, what should I do when I see my patient you know, out in the out in the wild, not in the dialysis center, right?"
Right.
And he was like, "What do you mean?" And I was like, "Well, oh man, everybody taught me like you don't acknowledge you like let them acknowledge you first." And he's like, "Morales, just don't be an asshole." Sorry, Richard Vanderplas just let me know that I'm still an asshole to this day. But he's like, "Don't be an asshole. Like, say hi to me. Like, you don't say hi to me, I'm gonna feel like you're snobbing me. Like, you know me. We're friends, right?" And
There
I,
you
I
go.
cannot I cannot disagree with you that so much time, so many stories. I'm gonna kind of share some of the comments. I'm not sure if they're showing up on your end, but Lorraine says
Yeah.
that sometimes the techs don't have, or sorry, the patients don't have anybody else to talk to, and you're their person, right?
Yep.
And I think over the years, I started clinically in the year 2000, working as a clinical technician, hemodialysis technician. I did reuse too, by the way. I was the guy who washed the dialyzer before. Um, but I remember at that time, it was pretty standard. Like we'd have 4 patients per shift. We were pretty well staffed. Like we weren't hurting for staff back then. Um, People didn't call in all the time. There wasn't these float pools and travelers and stuff like this. Like I really knew my patients and they knew me. And
Yes.
if I missed work, they're
Yes.
like, "Where the hell's Morales?" And if they missed dialysis, I
Yes.
was like, "Where the hell's so and so?" Right?
Yes. That is correct. Yes.
But things have changed a lot over the years. Staffing,
Yeah.
the delivery of care,
Yes.
the reimbursement of care, the devices
Yes.
that we use.
Yes.
California, then MPs became autonomous.
Oh,
Um,
they. Yeah.
yeah, so they can work, free of a physician presence. I don't know why I'm getting
Yes.
echo again.
Yeah.
Try and turn this down. So, what about the role of the NP? In your experience as a nurse practitioner, tell us a little bit about that role, and then in the case that it's not autonomous of a physician, like how much weight do you carry in the care planning, the prescribing, the intervention referral that in some cases only the nephrologist or the physician would be able to give?
So as an NP, I think you're pretty close to that patient and in the care that you give. And I think the conversation of whether nurse practitioners should be autonomous or not is a different conversation. I think that's a kind of worms that I don't want to open.
Messages on
God,
TikTok,
no,
but
God,
oh, come on,
no.
please.
But But I will say, I'll say this, right? Um, we've made the role, or we've made nephrology easy, right? And I think as NPs, our roles are going to constantly evolve.
Yeah.
Um, and that's sometimes dictated by how the reimbursements are done,
Yeah.
right? You've got a physician, one physician, and he's got 400 patients. How do you
Mm.
think he can see that those patients get very good quality metrics and not get in trouble? It's hard,
Yeah.
even if he tries in a month. And I think, in fact, I know that CMS requires that you see a patient once a week,
Hmm.
right? Um, three of them have to be limited visits, and one of them has to be a comprehensive visit. Um, I've seen physicians sometimes, because they're trying to catch up with their workload, park in you know in an emergency exit just so that they can pop in and pop out.
Yeah.
Um, and these are very good physicians, by the way,
Hmm.
right? Very, very great physicians. But it's almost like they're just trying to get the work done.
Yeah.
The role of the NP
Check off
has
the
come
box.
in, right?
Yeah.
But the role of the NP has come in and has made it easier for them to see a patient,
Mm.
um, take care of a patient, have great continuity of care, and better communication back to the physician if there is a supervising physician, right? Um, and most times, and I'm going to speak for myself, because I've been in the field for a long time. What happens is your physicians start to actually really trust you, and they
Mm.
trust your judgment when it comes to taking care of a patient. And even if they disagree with you, I think they can have that conversation and say, "Tell me what your thoughts are and why you're prescribing X, Y, and Z," right?
Yeah.
Um, or they can say, "You know what, I disagree with you. Let's try it from this." But the nurse practitioner gets a chance to really see that patient holistically, gets that patient ready for a comprehensive visit with the physician, so that when the patient sits in front of a physician, it's a great visit
Yeah.
versus a very hurried visit, right? So, and that's where I think nurse practitioners have come in. Um, you want a refill, the nurse practitioner is there to help you with it.
Mm.
Obviously, that has to be co-signed by a physician if there's a supervising physician. Um, the nurse practitioner picks up those little itty bitty signs and symptoms that a physician may not pick up in a 10-20 minute visit, right? But because we see them regularly, we can pick it up very quickly and make adjustments and changes immediately.
Mm.
um, Again, increasing that quality of life for a patient. So, um, with regards to a role for with regards to the nurse practitioner roles in nephrology, we need more. We need
Yeah.
more. We need
Yeah.
education, right? Who does the education? I don't expect the physician to sit down. As much as we like to think that physicians can sit and educate, they their workload is just so much that
Right.
it's physically impossible um, for them to do that. But no physician went into their profession to become a bad physician.
Right.
They all want to become very good physicians. However, other factors outside of care that are now determining how we provide care have, has just made it difficult. And so we need more practitioners that can help. We need nurses who can help with teaching, practitioners who can help with other ancillary issues,
Mm.
while the physicians provide care. And that's not to say again that nurse practitioners aren't providing direct patient care. We are, I do. Um, but that's because I'm in a state where we still need supervising physicians. And if you are not in a state that needs supervising physicians, the goal is that as a nurse practitioner, you still sit and you take care of that patient properly,
Yeah,
because again, you get to see that patient um, as a whole.
agreed. So, another thing I can't help but just as you were talking, many of the experience I had over the years as a hemodialysis technician, biomedical technician, even on the admin side, when it came to rounding of the patient, there's a lot of different styles there. And, we'll see a physician that calls and, I'm going to be there. And like you said, I'm going to park and I'm going to bang, bang, bang. And nobody come around because I got to do my thing.
Yeah.
And then I've seen other physicians that, well in advance say, I'm going to be here on this day. I need to make sure that the social worker, the dietitian, the registered
Yes.
nurse, and the tech that's in that pod normally with that patient, I want them all right there
Mm,
when I do the rounding.
mm.
What's your advice towards best practice on rounding a patient?
That latter part of what you've just said is something that we rarely see
Mm-hmm.
now, right?
Mm-hmm.
Um, it is best practice, right? Is it is it attainable? Yes. Is it what we see in real life? No. um, but we still have to provide great patient care, and so we have situations now where um, social workers are sometimes overseeing for 3 to 4 facilities.
Yeah.
The dietitians are overseeing 3 to 4 facilities,
Mm-hmm.
and the techs or even the nurses are sometimes agency techs, and they're just there to make a buck or two.
That's right.
And so there isn't that buying in wanting to be there. I think it's they want to work for the least amount of money, least work, most amount of money,
I feel you.
and but we still have to provide great patient care. And so I think um, the latter of what you've just said is what we would love it to be,
Yeah.
because it would provide great continuity of care, and we know that that translates into a lot of things, a lot of good things, a lot of follow-ups with patients. But we have to make do with what we have now, right?
Yeah.
um, Again, we have other factors that are determining how we get paid. We don't have enough staffing, and that includes for social work, for dietitian, and so
Yeah.
companies are having to make do with what we have, and ancillary staff is having to take on more work,
Yeah.
um, and so I think it's just boiled down to great communication. How do we communicate? We've also got other things I think that is also playing to our favor. We have technology, right? Where we want to talk about a patient, or we want to have a plan of care for a patient, we can all dial in and talk about a patient.
Mm-hmm.
And it could be an interdisciplinary meeting. It does not have to be a live meeting
Right.
anymore, um, to provide great care. So I think what you've just said is, or what I've just said is, we can still have what you said in the latter piece of what you said. It probably looks different from 20 years ago,
Tool
but
bag
then I
looks
don't also
different.
look like I looked like 20 years ago too. So
Yeah.
um uh and I think that so we just have to utilize technology. We have to utilize our EMR. We have to come ready to the table when it's ready to talk about our patient. Know your patient properly, look at the labs, sit down, have a face to face, even if it's once a month with
Yeah.
your patient. Get to know them, so that way when we're having a meeting about a patient, it is meaningful and it's goal oriented, to help a patient live a better life or more quality life.
I love what you say about the, best practice towards rounding leading to better continuity of care. And this is my own thought here, but y- maybe you'll recognize the company. Have you heard of a auto parts company called O'Reilly Auto Parts?
Yes.
I shouldn't be giving them a free plug, but O'Reilly. So
I
why
think the
just
ones that make the tires. Maybe,
I
maybe not.
think it's just like an auto parts store, but
Okay.
when I say O'Reilly, what do you think of?
Tires.
You do. All right. So you don't know the song, the O'Reilly song? I'm not going to sing it.
O'Reilly.
Yes.
Something.
So,
That's it.
man, why do you know that song? You know it because you heard it so many times, right?
I think so. Yes.
And it's catchy. Like, look, you're smiling about it. Um, I like to think about dialysis technicians as the O'Reilly song.
Yes.
Like, if I don't know what's important to you, I can't help to reinforce it. You know what I mean? And if it's important to you, it's important to me. As a
Yeah.
dialysis tech, it's important to me.
Yeah.
If
Yeah.
there's something specific about your diet that the dietitian is telling you and saying, hey, you really got to watch your sodium. What do you like to eat that's in sodium? Well, it's all my wife's food. Oh, shoot. Got to tell your wife stop cooking. That's my wife, right? She cooks a lot of sodium, but I need to understand what's important to you and how it applies to your life so that I can continue to reinforce. And when you hear it enough times from, I know this face doesn't look like it doesn't reek of care, maybe because I don't smile a whole lot. We were talking about this. Um, I think the people who know me, they know I care because I am acutely
I know you
observant.
care.
Like you mentioned about mom, I'm acutely observant. I got a sidetrack here. I got to tell you this story. So about a month ago, my boy, he's 11 years old, and he says, "Dad, Mom, I got to take my guinea pig. He's got a guinea pig, uh, to the vet." And we're like, "Oh crap!" I had just talked with CEO of one of the companies I work for, and he was like, "Oh, if you get a guinea pig and it gets sick, just go bury it because sorry, I shouldn't be putting him on blast, but he's like, because they get sick and they're frail." I'm like, "Oh crap, the thing's sick, right?" And I go, "Why?" I tell my son's name is Mason. I go, "Why?" Lorraine saying, "Oh, oh, oh, O'Reilly." So,
That's it. That's it. That's it. That's it.
so I said, "What's wrong with the guinea pig?" And he says he's going like this. I was like, "Blinking?" And he's like, "No, he's squinting." So I said, "Okay, let me see the guinea pig." And I walk over there into his room, and then it's like, we watched that thing for a half hour, and I didn't see anything. And I said, if he's not good tomorrow, if you still think he needs to go, we'll take him tomorrow, right? So he wakes up in the morning like early. He's like, "We gotta take the guinea pig to the vet." So his mom takes the guinea pig to the vet, and the stupid thing had a infection in its eye, and it had a some sort of lung infection or something. And I was like, I was so
that
proud of him, Lillian. I was so proud of him
the
because
blinks.
yeah, I was like, you know what, like you didn't give up. You told me what we'll call advocating, right, for our people. Like sometimes nobody
Yeah.
else knows, and sometimes it's the healthcare, one person on the healthcare team, right, on the
That
interdisciplinary
is,
team.
yeah.
Could be
That
the
is
tech,
correct.
could be the social worker, but we don't have those conversations and go like, what did you see? Then how can the person who's actually going to be making the interventional referrals or the prescription changes, how do they have the data that they need? So, one of the questions that came up in the chat was like, how much do you take in from the staff? Like,
Oh,
how important are the people that are there 4 hours of the day with the patient, either on a 4 or 5 or 6 to 1 ratio, and then the nurses who maybe what 9 to 12 or 15 in some cases. Like, how important is their feedback towards the advanced practitioner, towards the physician's decision making?
110%.
Mm,
And I'm going to speak from the perspective of a nurse practitioner. I'm sorry, a technician and a nurse, right?
mm, mm,
Nobody knows that patient better than a technician, first and foremost.
mm.
If your technician cannot speak about a patient, something is wrong somewhere.
Agreed.
And if your technician tells you that that patient gains a lot more, believe them.
Yeah.
Because again, they see the patients more.
Hmm.
And then obviously, if your nurse tells you something is wrong, something is definitely wrong
Yeah.
too.
Yeah.
So when I'm speaking to a patient, I'm taking into account every single thing. That includes objectively what I'm seeing, right? And what the technician is telling me. Do you know there are times I've gone into a dialysis unit and for the life of me, I had a patient who was very compliant with his phosphorus binders. But we could not I couldn't understand why we could not get his phosphorus within control. Um, I called his pharmacy. I was like, "Is he picking up his medications?" And they went, "Yes, he's picking up his medications." We adjusted his doses. At some point, you can't just keep adding phosphorus binders. You have to
Yeah.
find out why they're not working. We changed his binders to cover him more. Still wasn't working. And so one of the days I was at the nurse's station and I was trying to put my notes in, and I casually just said, I was actually talking to myself and I said, I wonder why I can't get his phosphorus within control. And it's only going to be a matter of time before he gets very uncomfortable and he starts scratching.
Yeah.
And I was just talking to myself and I was getting ready to put my notes in. And and the tech turns around and says, "Have you opened his blanket yet?" Yes, I
Ten
do.
pieces of
When
oxygen
I'm
or what?
checking his legs, and he said, "No, seriously, look behind him." And I said, "I do because I have to listen to his lungs. So I have to have him sit up and to listen to his lungs." And he went every time he sits up, just ask him to scoot a little bit. Needless to say, I did that right after he said that. I went back to the patient and I said, "You know what? I need to assess you one more time again. Let me just check something." And I did that and scooted him even more forward. And I saw the bag of snacks he had. And I was like, there you go. That's why I just have not been able to get your all of the things you were not supposed to eat was in that Ziploc bag,
Yeah.
right? And that's why we were finding it difficult getting his um, phosphate under control.
Yeah.
Um, so the techs know this patient inside and outside. They know they're going in, they're coming out. The patients talk to them about every other thing that you things that you never think that would affect and have you tailor your care to a patient. The techs know it.
Yeah.
And once the techs know it, they communicate it to the nurses and everybody's in the know. And that allows us to actually come in and not just have a square peg in a square hole
Yeah.
sort of healthcare approach to a patient. You're able to tailor that conversation to a patient. You could have a list of things you want to talk about to a patient, but then at that time you're thinking about what's your priority and how do I approach this patient with this particular topic, knowing this patient and not just talking straight way to them because then if they don't listen to you, that message is lost anyway, and you're just talking for nothing.
Yeah. I can't help but think as you mentioned, kind of the snacks and the lab values, and this is a hard disease. I mean,
It is.
kidney failure is nothing that I wish on my worst enemy. Uh, and I've grown up with, as you said, and I'll agree, some of the my closest friends in the world have been sitting in those chairs. People who I will remember till the day that I stop breathing. And some of them, it was very fun. And they, like you said, they ask me how I'm doing. And it's more than I ask them how they're doing.
Yes.
I can
Yes.
remember a patient that, she asked me one year, "What are you doing this weekend?" And I was like, it's my oldest daughter's, now my oldest daughter, it was her like first or second birthday. And a year later, she had a Christmas, or not a Christmas card, a birthday card for my daughter on her birthday. And
Yeah.
and I mean, I was a very young man at that time, and that taught me, like, man, you got to pay attention,
Yeah.
because look how close attention this lady paid to me, and I'm supposed to be the one that's caring for her,
Painful.
right?
Yes. Mm-hmm.
And I got to have like some of my most fond memories. Lillian, were providing direct patient care. As a dialysis technician, it's the most proud thing that I've done in my life outside of fathering four beautiful children. That growth, right? But to be there for people in these times is it's the most fulfilling thing for me.
Yeah.
And as I look at 25 years later, I'm concerned sometimes about the things that we're talking about, just the shortage of staff that we have, the work ethic that we have here in the United States today when we talk about, the least amount of work for the most amount of money. Ask somebody today to be a preceptor, and holy crap, like their answer is like, how much am I going to get? And it's such a hard time. And I remember, back when I was
It
on
used
the
to be
front
an
line.
honor to be a
Yeah,
preceptor.
man, it was like, shoot, let's
Yes.
go, right? No, not today.
Yes.
I'm not saying everybody out there's like that, but it just things have evolved. So let's talk about that. Let's go with the good. Let's go with the bad. What from your time in as a dialysis technician into a nurse practitioner, healthcare leader, uh, what have you seen? Good, bad, and then let's say good, bad, and what's exciting.
So, so what have I seen good? I'll tell you this much,
You like to
right?
start with the good.
Um,
Okay.
yes, you always have to see that glass half cup full.
Okay.
um, uh, the fact that we can talk about other treatment modalities, knowing that we don't have enough healthcare providers, has been awesome. Because it used to be one straight way. Once you were told you had ESRD and you had to be on dialysis, it was hemodialysis. Well, that isn't the case anymore. And you don't necessarily have to give up all your power, sit in the chair, and rely on someone to take care of you.
Yeah.
So, even now, more so as I start to see younger folks get on dialysis, my first question to them is, what are you doing on the sit?
Mm.
And why are you not home? And so I think what has come out of this situation is more advocacy for treatment modalities, having patients own their power back. Because, you know, having to sit on the chair, you're back to the chair, you lay back. Yes, well, that can be easy, but that's also giving all of your power away,
Yeah.
right?
Yeah.
Um, I'm not saying that that's the worst thing that can happen. I'm just saying that if you can get your time back, um, and not have to sometimes, as you know, fight with your technician, why won't you do that?
Yeah.
So I think what has come out of all of this has been the push for home hemodialysis, the push for peritoneal dialysis, allowing them to have, um, allowing patients to have the freedom to choose. Um, I don't want to say maybe placing patients on transplants, preemptively putting patients on transplant is because we're still um, pushing for that a lot, but at least having that discussion and letting them know, beforehand. But more important, I think treatment options. And
Mm-hmm.
so you see a lot more patients as they get comfortable choose to go home um, to get their dialysis. I will say, I remember um, I think it was Dr. Kazim, but I was on one of his lives one day,
Mm-hmm.
and he had put up a question about if you or your family member, knowing what we know about dialysis now, if you or your family member had to um, go on dialysis, what would you choose? Would you choose in center hemo or would you
Yeah.
choose home? And I think
It was
I want to say
overwhelming.
99% of us said
It was
home.
overwhelming. Yeah. Overwhelming.
Yes, it was over. Everybody said home. Almost everyone said home. And that's because we now know what we know. So then, can you imagine if we know what we know, if we can take what we know and tell patients, teach patients that earlier on, most of them may just choose home.
Mm-hmm.
And so that may take care of the issues of um, shortage of staff, and we can use staff for actual acute or chronically ill patients, right? That need it in the in center.
I feel the
Um,
same.
yeah.
Yeah, you
So
walk
I
in,
think
you're
that's
talking to me with high aptitude. Like I asked the same question. It's like, what's stopping it? And Lillian, is that is required is to actually provide treatment modality education as well as a justification why they are not doing it at home.
it is, but I think we see the reverse now, where the patient's already in the chair. Sometimes four, five, 10 treatments into the in the chair before you then start talking to them about treatment modalities, and that should not really honestly be the case. I
Yeah.
think um, we should start preparing patients way ahead of time, and I think this is where the value-based care companies can really make an impact
Mm,
in bringing value to um, patients who have CKD4, maybe even 5, maybe CKD3, start preparing them. I
yeah,
mean, the goal is never to get on dialysis if we can help it, but there's still a portion of patients who will end up on dialysis.
that's right.
And so the question then becomes, how do we make sure that they're living their best lives? And there's some patients that no matter what we do, they will always end up in hemo.
Yeah.
And that's what we're there for. That's what the technicians are there for. That's what the nurses are there for. But if you can do it at home, I think my thing is always go home and do it. I've seen some of my best patients um, do well at home. When I oversaw the home programs with Fresenius Medical Care, I
Mm-hmm.
oversaw the northern New Jersey area, the New York and the Connecticut area.
Mm-hmm.
And some of my very best patients were home hemo patients. You rarely saw them in the clinics. And when they came into the clinics, they could not wait to get back out because a lot of them lived lives,
Yeah.
their regular lives. They kept
Yeah.
their regular jobs. Um, they almost incorporated home hemo into their regular lives that
Yeah.
they didn't want anything to disrupt it. And if they ever had to come into the clinic, oh my God, you could see the distaste on their face,
Yeah.
right?
Yeah.
Like, why am I in here? And why do I have to do it? So unless they absolutely have to, I had a patient one time who was moving houses, and I think his house was being renovated, and so he couldn't do it at home for the 3 months he came into in center. You heard every bit of it.
Yeah. Yeah.
He didn't like it. He told you he didn't feel very good. He didn't feel like he was very well cleaned. You name it.
Mm-hmm.
Even though, I mean, some of it was subjective, but you name it. So he couldn't wait to go back. He lives a very great life. He works in a corporate world. So he just couldn't wait to get back into his space. So I think the good that has come out of this is we're pushing more treatment modality. I don't know what the bad is. I think I have to think about that. The bad is we've just gotten people who've gotten into the business and just want more money. Want more
I'll
money.
agree with it. And it's not just
Yeah.
on the business side. It's, I mean, let's talk about healthcare just briefly. Is it a sexy occupation? Like,
No.
I mean, let's think about 2025. Like, yeah, I get out of high school and then I see this, crypto stuff and I see, Airbnbs and I see, I can do aesthetics or things like this. Like, is going and doing bedside care
No.
treatments like hemodialysis, is it a sexy job these days? Is it a sexy
No.
occupation?
No. And that's why I said to you that um, direct patient care, you just have to have the passion for it because there are days that are just going to be very difficult. And what's going to carry you through is your passion. But is it sexy? I mean, unless we want to, what's that program that has McDreamy in it? That is
Oh,
everything but healthcare.
I don't know if it's Scrubs or Grey's Anatomy. Grey's Anatomy.
Grey's Anatomy,
Yeah,
right?
yeah.
Unless you're, and even that is not even pretty. But unless you want to be on
That's the
Grey's
only time it's
Anatomy with
sexy
all
when Dr. Dreamy or Dr. McDreamy. Oh gosh. All right. Now we know. Now we know.
I'm gonna get in trouble, but
So
but Healthcare is not. Healthcare is not. No, no. Direct patient care. No. I
Do you know
think
a
we
place in the
do
world
it.
where it, do you know a place in the world where there's not a shortage of nurses?
No, no,
I know
because
of one.
everywhere is looking to
I know of
where?
one.
Dubai.
Philippines. Philippines. They have like
Okay.
over 3 million nurses that are not actually working in hospitals. Call centers
Oh,
are full of nurses. They have NCLEX
awesome.
passing nurses. And it's actually an occupation that in the Philippines is actually not sexy at all. They don't make very much money. But their number one hope is that that profession will lead to deployment to a first world country
Right,
where
right.
their wage would go up like 20x, like if they were to come to the United States.
Michael, I have a question for you. Does the number of nurses there equate to the quality of care that is there, that is being gotten out of there? So, in other
Um,
words,
I would say
uh-huh,
no. I would
uh,
say no. And glad you brought that up because, thinking about a Medicare-like system, right? Philippines has a Universal Care Act now that
mhm,
they include ESRD, end-stage renal disease, and shout out to
mhm,
all my friends in the Philippines, especially those in Parañaque. Like, there's a lot of stuff going on in the Philippines from a governmental
mhm, mhm,
perspective where they've
mhm,
actually really thrown some money in the pot as far as reimbursement from an agency or an
mhm,
entity called PhilHealth
mhm,
to equate to the time and frequency that we deliver here in the United States. So they can get 156 treatments per year now
mhm.
in
Oh, yeah.
dialysis centers reimbursed by PhilHealth. Standard of care, here's their list, here's our list. So there's a gap there. There definitely is
Okay.
a gap there. Um, but it's interesting that we're talking about nurses. There's no shortage in the Philippines. When we talk about kidney disease as well, this number is nuts. Close to 40% of the people in the Philippines have chronic kidney disease. This is a massive problem. I mean, when we look at the numbers we have here in the United States, you know, 1 in 7 or so, right, having CKD, um, they're leading the pack globally in the
I'd
Philippines, and
like
there's a lot of
to,
reasons for that.
that's interesting. I'd like to also know, and I'm sure it's the same reasons I'm just getting ready to say. I'd like to know what that number is in the African countries as well,
Yes,
because there are a lot of predisposing factors that we have already that make us candidates for CKD. Um, Unfortunately, I don't know that the universal healthcare system is something that is
not as
um,
not as
I,
available there. Huh?
it's not as robust as it is
Yeah,
in the first world countries, and um, with diabetes and hypertension leading the way.
yeah.
um, so it'd be interesting to see what that number looks like if the Philippines has 40%. Um, it'd be interesting to see
It's
what the
nuts, right?
African countries have. Yeah.
What do you know about genetic markers and predisposition from a genetic marker perspective? Because when you mention those of African descent, I attend a lot of. Actually, saw Dr. Shika at a Long Beach NKF
Yeah.
area meeting, but they
Yes.
were really talking about genetic markers and APOL1
Yes.
specifically. I
Yes.
was blown away because I had no idea that, yeah, of course, type 2 diabetes, hypertension,
Yes.
that's
Yes.
walking you towards this other comorbidity. But at the same time, if you have that genetic marker, you're much more at risk for
Yes.
chronic
The
kidney disease.
APO.
And then
Yeah.
learning about the effects of actually getting a transplant and it acting on that grafted organ as well, that blew my mind. So what do you know
Yeah.
about that? Any color you can add to genetic markers, rare kidney disease?
Unfortunately, not very much. I'm not very well versed with it. I'm still
Hmm.
actually educating myself on the APOL one. So I think um, I know as much as what you've just said, and I'm still learning.
Are you
Um,
seeing patients that want to come in and get genetic what's the right word for that, genetic testing
we
and
to get tested genetically.
yeah,
No,
you're not.
That's now even in my CKD population now,
N- Yeah.
which is interesting. Yeah.
Yeah, I mean, I just kind of heard that the genetic testing might be a little sensitive because when you look at, let's say, I think the data today shows the APOL1 is higher incidence with those of African descent, that it then begins to kind of
Yeah.
stigmatize and create some sort of health equity type of issue. But it's up until now, it's been unknown, right? So it's like, all these things we've known over the years, that type 2 diabetes and hypertension, but then you throw in a genetic predisposition, it makes it even more complex and even
Yeah.
more, Lorraine says, test people early, even more
I
reason
agree.
for this.
I agree. So I know bits and pieces of the APOL1 genetic marker. Um, I know that there is the piece where it affects the African American population, African population, or
Hmm.
anybody of African descent.
Hmm.
Um, I may even there might even be a piece of it that even has to do with melanin.
Mm.
Again, I don't want to speak too much on what I'm not very sure of. And so I think maybe on my next time sitting with you, I'll educate myself more on that and still getting to know more about it. So,
Well, I think
um,
that's the takeaway there, is that there are new advances in diagnostics
yeah,
that say that there's more than we know.
yes,
We're still learning a lot, right? And
yes.
that kind of goes into, let's talk about transplant a little bit. Like,
Ah,
what's changed there? I mean, not just transplant, but like when we talk about immunosuppression, and then we talk about some of these preventive medications, like you said, let's
yeah,
prevent it when we can. I just had a conversation with
yeah,
a good friend and one of our mutual friends, Dr. Yasser Kazi, yesterday, and he says, like, go look around at NKF. I'll be at NKF in Boston tomorrow, leaving tomorrow morning. National
okay,
Kidney Foundation spring clinical meeting. He said, go look around and you're just going to see all these companies that are on the preventative side today. And, they're kind of stepping over each other's toes because so much is happening so fast.
yeah,
But a lot of this stems from the work of transplant nephrologists and the transplant centers, and understanding immunosuppression and yeah, immunosuppressing drugs. So,
hmm,
what sort of color can you add to today's um, the landscape of transplantation, whether it be from cadaveric, whether it be from living related, whether it be the swap programs? And before you say
yeah,
that, I just want to share a story I shared with you, I think today or yesterday.
yes,
But something that's really heavy on my heart right now. And some of you have seen that I've been helping actually quite a few friends as of lately that are looking for kidney transplants, helping them to navigate, helping them to share their stories. And have a good friend that he is advocating for himself for living donation. He's got over 50 candidates that have come forward and said, take one of mine. And he's having a hard time in kind of getting that whole ball moving with so many people, to where there's like a limit of how many people they can go through. Uh, this is a gentleman that, through his life and career, has taken the bull by the horns, and anything that he puts his mind to, and
hmm,
he moves fast, and he moves
hmm,
efficiently, learns fast. So this is a whole new story for me after my whole life in dialysis and nephrology, hearing somebody say, like, I have a lot of people that want to come forward, but they're being held at the line, they're being held at the door. What can I do? And Dr. Yasser Kazi kind of gave some initial guidance here, but it just shows how much more we have to do in the transplant realm. So, um, any thoughts?
education,
Education.
education, and education. Um, I think we can't give enough education to our patients on um, how to get on the transplant list, how the transplant list works, or how allocation works. Um, I still don't understand why the patient has to be on a chair before they get to know about. It's still, this is 2025,
Yeah.
right? Why does a patient have to be in a chair before they get to learn of how they can get on the transplant list? Um, the other day, I also got a chance to speak with Dr. Kazi, too, very dynamic speaker,
Hmm.
by the way, if I must say so myself. And I learned so much about transplant just by talking to him. And he talked about how we've been able to eliminate. It used to be what you could only be on only one transplant list per state,
Yep.
and you had to be in the state. And so, God forbid, if you were in my state, you had to stay 6 to 7 years before getting a transplant. But now it's you can get on more than one list in a state, and not just that. Um, you can actually go outside to neighboring states and get on as well.
Yeah.
I didn't know that,
Yep.
right? Until
Yep.
he spoke to me, until he spoke to us that day, and that was very interesting. But I can guarantee you, if you go out to the dialysis centers and you ask them, actually, right after I spoke to him, I just did a survey for myself while rounding one of the days when I round. And I just asked my patients that were on the transplant, did you know you could get on two transplant lists? And they went, no, no, are you serious? You can? Yeah, I'm like, yeah, you can. And they don't, you can get on this one and that one over there. And they went, you really can? I didn't know that. Now and the same time, you can, the same allotted time that you have, you get for both sides of the hospital. And so if patients are not aware, clearly we're not doing a very good job educating our
Yeah.
patients.
Yeah.
And so whether there is the technology, whether there is immunosuppression drugs, whether patients have to get on the transplant list first
Yeah.
for us to bring the rest of the other things to the table.
Yeah.
um, and if they're not getting on the transplant list, or don't know how to get on the transplant list, or are getting on later, then we're not doing a very good job educating them. So I think um, education, education, education. Um, Educate your patients, educate yourself to educate your patients. um, and we just have to make sure that we're keeping on with the trends on what's going on. With regards to transplantation, I really like that we're coming up with different ideas. I like that there's xenotransplantation going on.
Mm.
Yes, be it that it's, I think the first couple of ones were not successful. We may have just had one successful one that I
Yeah.
think was done earlier this
That's right.
year, and
New York,
the
right? I
patient,
think at oh gosh, I forgot the name. Langum, if I'm not
yes,
mistaken. Yeah.
yeah. So I like, because for the longest time it was just very quiet. The nephrology world was just quiet, and it
That's right.
was just status quo. So the fact that we're getting different things that are shaking the paradigms, that is shifting the paradigm, is awesome, and that includes technology and transplantation, um, even transplantation itself. Um, that's awesome. It only gets better from here, I think.
Yeah.
Um,
I hope so. I hope so.
Yeah, it only gets better from here. And then your friend, for instance, who has uh, people who want to donate a kidney to him. Um, yes, there are different criteria. If you've ever seen somebody donate a kidney, believe me when I
They've been good.
say that they've been wiped clean,
Yeah.
and that there isn't any disease lurking around.
Thorough evaluations. Yeah. Yeah.
Right,
Yeah.
right. It's very, very thorough. And even now, I think there is even a push for the pool. So I can talk about her because she always wants me to share her story. I have a patient who got into a pool um, of kidney donations,
Yeah.
where her mom donated a kidney. She didn't get her mom's kidney, she got somebody else's kidney,
And somebody else got mom's.
uh,
Yeah.
and then somebody else got mom.
Yeah.
So the strict guidelines that used to guide transplantation, I think, has been helped with a lot of the medications, a lot of the immunosuppressants that
Hmm.
that are in the market, a lot of technology. Um, so there is more transplants going on, and I think, if I'm not mistaken, I think that's even one of the um, value-based care KPIs that have to be looked at, as in the amount of transplants, the amount of patients that are on the transplant list, and the amount of transplants that are being performed,
Yeah.
are part of what or what CMS is looking at this time. And so we're seeing more transplants now than we've ever seen before. I mean,
Last year was a record breaking year, wasn't it? 24?
really,
Yes.
I'm sure.
From
I'm sure because literally in the practice
quote
where
me,
I
don't
am, and it's
unquote
a
me.
practice.
Quote me, don't quote me. But yeah, like, I believe last year was the highest, a record setting year for transplants.
Yeah,
And,
I believe you.
innovative and thorough people like Dr. Kazi, I think, are
Yeah.
are are contributors to that. So you mentioned KPIs, and Lillian, I know we've been on for a couple hours, and it's like late. You're in New Jersey, so
It's
I just
okay.
have one more topic that I'd like to
Sure.
dive into a little. You talk about KPIs, and you talk about modality education, and you talk about transplants, and I mean, hey, if you were my nephrologist, I'd like to know how many people you put the brakes on CKD as well. If that's a metric we could know. I don't know if we can know that one, but you know what I'm saying? Like, you got 1,000 people in your under your care as a nephrologist. Like, what's the rate of progression to CKD5? How good are you at stopping it, doc? I'd
Love
love to
it.
know those things. But most people, and I'll say especially those that are most affected by kidney disease in the United States, type 2 diabetics, hypertensive, heavily influenced by like an urban population, a dense population, right? Which there's often a lot of people of color in those areas, right? We see that it may creep up because, I mean, I'll speak for the Latinos out there, and the Latino men, that a lot of times we won't go to the doctor until, and we're jacked up, and everybody knows we need to go to the doctor, not just me, but everybody around me knows that something's going on, right? That's when I'm going to go. And I go to my primary, and they go like, hey, you got type 2 diabetes, and you're spilling some protein in your urine, and I need you to go see Dr. So and so in a couple days. That's a nephrologist, to take a look at your kidneys, right? And you go in there, and they go like, well, we've already seen your blood work, and you got CKD5, and we need you to go get a catheter, and you need dialysis right away. That's not exactly the
Crashing.
time that I want to shop. Right? Like, and I want to shop, right? Like, hey, for me, if I had to stop working, that's the worst thing you could tell me.
Yeah.
And I've never been in a place where my health is at, a critical nature. But when you tell me my health is going to make me to where I couldn't stop work today, I would be devastated, right? So if I was going to go shopping, I'd be looking at, all right, which one can I do home? Which one can I do if I got to go to a center? Which one has a late shift? Which
Mm-hmm.
one has good outcomes?
Mm-hmm.
What's your
Mm-hmm.
advice to people who have the time to shop, or they're just hearing this, and one day they find themselves in that crash scenario? How do I find out what's going to fit me outside of what my doctor tells me? And this is going to lead into what I think is bad today. So I'll stop. I'll start with that part. How do I go about looking into these programs, whether they're dialysis or transplant programs, to find out if it's the right fit for me?
Education again. So let's rewind and start from the beginning. Everyone should be able to have access to healthcare,
Agreed.
right?
Hmm.
Um, and this is why, regardless of what's going on, the DEI stuff,
Mm-hmm.
healthcare equity is still very, very important. I've been privy recently to be in a university hospital where you'll be very surprised how the social determinants of health
Yeah.
play a huge role.
Yeah.
I think um, it's one thing when we say it and you see it every now and then, but when you actually see it play out,
Mm-hmm.
um, it's very scary.
Yeah.
And so, health equity, access to health care is very, very important because that's what's going to make a the African American man, the African man, the Latino man go see the physician, right? Um, um, and get their annual checkups. Um, Allow them access to care to take care of their chronic diseases, right? Without fear or that they'll end up with X amount of money or out of pocket money.
Mm-hmm.
Um, so that's going to play a huge part in all of this,
Mm-hmm.
right? And then the education also comes in. When there's education and there is access to care, I think the outcomes are will be better, right?
Yeah.
Because um, you're either in prevention mode, which then allows you not to crash into the hospital, or you're in complete you're completely taking care of yourself
Yeah.
and not allowing it happen so that you don't go into prevent well everything goes into the prevention mode, so
Yeah.
you're in prevention mode, right?
Mm-hmm.
And
Mm-hmm.
that if it does happen, you've allotted yourself enough time to again educate yourself on the options that are available out to you
So
there,
preparation,
right?
prevention and preparation mode.
That is correct,
Yeah.
yes.
Yeah.
um
So I gotta give you another story here.
yes.
I met a young man recently. He's Latino. He's later 20s. He's a
Hmm.
hemodialysis patient,
Hmm.
and I showed him something called the dialysis facility compare. You
Hmm.
may be very familiar with this, right?
Hmm.
Medicare website. I can type
Hmm.
in I can just Google this dialysis facility compare. Right? You got somebody who you think may need dialysis one day or has been told they need to do dialysis.
Hmm.
If
Hmm.
if it's my family or if it's me, like I said, I'm going shopping.
Hmm.
I'm a consumer of dialysis now, right?
Hmm.
Do I want to go to the McDonald's or do I want to go to the Michelin restaurant? I don't know.
Which may be far away from you, by the way.
There you go. There you go. So all of that are things you can look at within the dialysis facility compare, right? I can look
Hmm.
at distance from my home. I can look at the shifts that they have available, the days they have
Hmm.
available, the
Hmm.
modalities they have available.
Hmm.
I said the shifts already. So, like if they have late shifts,
Hmm.
I can look at their outcomes. I can look at their patient satisfaction. And, you know, there's only a face value at that, right? Like you still need to
Yes,
go in and kind of take a look at things because there's a lot of the ratings are heavily related to the actual demographic and the comorbidities and the age of the patient population, right?
that is
But
correct. Yes.
when I think about again, just if I put this personally, if I needed to have hemodialysis tomorrow, probably the first thing that's on my mind is for me is what about work?
Hmm.
And the bills don't stop, and my
Hmm.
kids are at a point where they need help, and I have two living
Hmm.
parents and two grandparents that are
Hmm.
living. I have
Hmm.
grandkids,
Hmm.
right? So like I'm thinking about this whole five generation of people and what I contribute to them. I need a shift that's gonna fit for me. I can't have you tell me, Morales, go over there from 8 to 12 on Monday, Wednesday, Friday, and you're gonna have to do dialysis. That's the chair time they got. I can't have you tell
Hmm.
me that.
But that's what happens sometimes. That's
It
what we
is.
see.
You're
Yeah.
right. Yeah. So, when I think about because I asked you the question over my career, good and bad. I think the narrative behind home dialysis, home modality, definitely improved. I still don't see enough about prevention. I'm just being
Mhm.
honest with you. I just don't see enough value, emphasis, execution of prevention of CKD5 out there. Pre ESRD education, which is a billable item, like people don't do it. I don't know why, right? Um, then when you talk about kind of, well, not necessarily you talk about, but like the one transplant list. Oh no, you can get on more. I've actually heard transplant centers tell the patient like, well, you're gonna have to come off of our list to be able to go
Mhm.
on that list. And I don't know if that's a scare tactic or what. Is it a competitive statement to try and hold the? I don't know, but I think that we're all on the team that is not our company. It's not what it says on our scrubs. It's John or Jane or whatever the person that you're working for. That's the team I play for.
Yeah,
So if they
yeah,
got to go somewhere else to get the best fit for them, like I know I'm a okay with that, even in an administrative role. But I would say
yeah.
the thing that bothers me today is that I'm not sure that everybody's playing on that same team. And you don't have to agree with me because I don't want to get you in trouble here, or get you a bunch of LinkedIn messages. But I wish that we all saw the team as the one individual that we're
The
working
patient's
with.
team.
Yeah. Yep. Feel free to
So,
weigh in or pass.
so I guess what you're trying to say is the downside to all of the changes that we've experienced over time in dialysis with the new technology, the new innovations that we have is everybody wants their product to be better than the last person's product, right?
Service or
And
product. Yeah.
so and so because of it, what we see is we see scare tactics where um, products are being presented to patients as being more superior than the other, even though it's doing the same exact thing. Is that what you're
Or
trying to
the
say?
only. Yeah. Or the only. Yeah.
Oh, you're right. Right. All right. There is a business to every side of every company, right? At the end of the day, I think we are all looking for great patient outcomes,
Yeah.
right? But there is a business side to it
Mm-hmm.
as well. And healthcare is a business
That's right.
as much as it's just like going to um, the hotel business, right? The hotel business aims to take care of you. So think about it. You go from hotel A to hotel B. Hotel B wants to outdo hotel A, even for a cheaper price. And, but they're still providing you the same thing, the same It's still accommodation that they're
Mm-hmm.
providing you, right? So I want to think that healthcare is the same way as well. It is a business, um, product or not. Again, this is where education comes in, um, for a patient. The trick, like you rightly said, is when you don't have enough time to shop around,
Yeah.
then you really have just given your power to whatever product falls on your lap,
Yeah.
right? And that's why that prevention has to take place. That's why that access to healthcare has to be accessible at all times, um, where we can make sure that every and anybody can come in and get healthcare screened. Um, you know what comorbids that you have that put you at risk for any sort of disease, quite frankly, at this point,
Mm-hmm.
so that you can get to understand A, the disease, B, shop around, right? And C, get the power to be able to make the options or to take the options that you want. Um, but healthcare is a business. So I'm not going to stay here and tell you that companies are not looking to make a profit. It is a business. Physicians are there to make you feel good. Like I said, no physician, no healthcare provider goes into a business saying, I'm going to make this patient feel worse than he came in today.
Yeah.
That's not the case. I think that combination is the combination of the business piece and providing great quality outcome is where personally I've built my business, I've built my career off of, right? How
Mm.
do we provide great because healthcare is expensive. And if you think prevention is expensive, try getting that disease and see
Yeah,
how
that's right.
expensive it can get, right?
Yeah, what's that? A ounce of prevention is worth more than a pound of treatment. Some I don't know. I might
That
be
that is
butchering that.
correct.
Yeah.
That is correct. That is correct. So um, the goal should be how do we prove, and this is going to be an ever evolving answer, because the goal of America today should be how do we provide great quality healthcare without breaking the bank of people,
Mm-hmm.
without breaking people's banks. Um, and this is
That
where
should
you
rally
see
up a bunch of comments, by the way. That should rally a bunch
competition.
of comments because, you know, you can look at
And this is,
videos of the 70s and PE and stuff like that and look at our
yes,
food, and there's probably a million answers to that question. Yeah.
yes, yes. And this is where competition comes in. So for me in the nephro world, I love that we have a lot of competition. What's better than what that's still yet to be seen, because it's all new, right? And
Yeah.
so we're getting to see how different things work, what the outcomes are going to be. But I love that there is competition and there isn't just that marginalized set of folks that have the technology or the ability to take care of people anymore. So that I like.
Yeah. Lillian, let's end with a couple funny questions.
Sure.
So I remember years ago, and this might not be so funny, but it's funny to me. Uh, I was introduced. It was probably like 2010 or so. I was at a California at the time California dialysis conference meeting, a board meeting, and the executive director comes over to me and says, "Hey, uh, this gentleman, John Sargent, wants to talk to you." And John Sargent is kind of a pioneer in the dialysis world, part of one of the guys who derived or created, developed the KT over V and
Yeah. Yeah.
PCR, and did some work with hollow fiber dialyzers, and just really,
Hmm.
you know, a scientific PhD type of guy that brought a lot of value to the
Hmm.
diagnostic side of the industry. And I was like, what? He's like, oh, you know who he is? And I was like, yeah, man, I was like, I'm a dialysis nerd. Like, I've been reading the book since I was like 14, right? And like, I see his name all over the place. So I was like fanning. I don't know if that's the word, but uh, who would be your uh, subject matter expert, physician leader, business leader that would make you a fangirl? You know, that would be like, oh my God, I'm meeting so and so.
Ah, over the years I've had so many, and I've been blessed to be trained, be friends with
Not
so many of them.
McDreamy, by the way. Not
Me,
McDreamy.
no, 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 McDream. No, no McDreamies yet. I was trained by Dr. Chenet, William Chenet,
Okay.
very well known in the Newark, New Jersey area.
Mm,
Um, and I feel like every single sentence that came out of that man's mouth, he's retired now, by the way, but every single sentence that came out of his mouth meant something. It meant I had to go research something. It meant I
mm,
had to go look up something. It meant I had to, um, everybody had to be treated with respect,
yeah.
right? That's someone that I constantly fan out to. I still reach out to him even till tomorrow. And then I have the ones um, that are my friends.
Hmm.
Dr. Alice Way.
Yeah.
I, I talk about her all the time because can talk and I can laugh with her. We can talk about patients. We can disagree about subjects, but have meaningful conversations. Um, Great nephrologist that I've had the opportunity to also work with. I actually met her working with her
Mm, mm,
initially in Fresenius. Um, I don't know that I have any particular. Everybody brings something to the table, right? Um, Everybody brings something to the table. I've met so many people over my career, and they want nothing but the best for every patient, and you just have to see it from the perspective.
yeah,
And so I don't know that I have any person that I look up to just yet, but I do revert a couple of people. So Dr.
yeah.
William Chenet is one of them,
Hmm.
and his daughter is actually also a nephrologist as well
Oh
too,
wow,
and he trained me. Yes,
carried it on. So I gotta
yes,
say that just for those of you who have been with us since the beginning, when I met Lilian at the ASN, there was this vibe group, right? And Dr. Wei and I'm sorry, I always mess up with Dr. Shika's last name. Is it
Dr.
Popo?
Papo, Dr. Shika
Popo?
Papo.
Yeah,
Yes.
just I mean, I know them by reputation and by affiliation and demonstration and different sort of discussions, and it's always been very high level, and then definitely patient centric. So I can say that I definitely fanned on them, from the first time I met them. But the
Oh,
three of you as a group, uh, I don't know if you could tell, but I wanted to hang out with you guys. Um,
oh,
and I was so glad when you reached out and said, "Hey, Morales, but it's time for us to have a conversation." Really
yes,
appreciate you
yes.
being here tonight, and also
Thank you.
appreciate Tim Fitzgerald, who I
Yes,
believe just kind
Tim.
of put the pieces together that evening,
Oh
and
God.
brought us
Yes,
all together. I think we all
yes,
have a very similar passion for sharing stories, sharing education, all for the
yes,
betterment of the teams
yes,
that we
yes,
play for. Which I'm glad
yes,
we agree that the team is
yes,
that patient, the one by one
yes,
patient.
yes.
Um, we've got a friend here from LA. He's asking if you know Karen Evans. I believe she's out in New Jersey as well.
Karen
Um,
Evans. I may know her. I may know her. I may not know her name, but I may know her facially.
she's great. Yeah, she's a
Yeah.
nurse with, I believe, one of the big, or MDO, dialysis center, or
Yes.
administrator
Yes.
with one of the
Yes.
MDO providers, and somebody who I actually know really cares a lot.
Yeah.
So I want to thank you. Go ahead. I'm sorry.
Let me just quickly shout out to a couple of people.
Yes, please.
Team has Team is doing a very great job putting the different bits and pieces together. So
Yeah.
he's I think sometimes we find it difficult to tell our story succinctly, like
Mm,
put it together, especially the business piece and the clinical piece.
yeah.
And Tim is doing that in a very great manner. And so I just want to say thank you to him. For someone who is not clinical, he's doing an
He's
amazing
a
job.
data master for sure. I mean, he's been
Right,
praised by so many. Definitely a
right.
guy, like you said, not clinical, but definitely somebody to look at and
Yes.
look up to, because I know his
In the
heart's in
right
this.
place.
Yeah, it's definitely
Yes,
in the right
yes.
place.
Dr. Shikar Papo, I met while at Strive Health, and very one of the coolest people. Very relaxed,
Yeah.
very relaxed, but she knows her stuff, and she
Hmm.
comes with a lot of grit.
Yeah.
And so um, I really, really respect her a lot. And Dr. Wei, I think I love Dr. Wei. She knows I do. She knows I do her. I talk to her every other day. I text her. I say the dumbest things to her, and she's like, Lillian, that's a dumb
Oh
conversation.
yeah, straight up.
Yeah,
Absolutely.
yeah, yeah,
All
yeah.
right.
But I've also met some very prolific people. Dr. Amaka and
Hmm.
I met sometime during an RPA conference, and she was very instrumental with being able to give a lot of African Americans back some time on the transplant list. I thought
Yeah.
her work was very good. I got a chance to listen to her during the RPA conference, and for once, I saw someone talk about race and not feel very weird about it.
Yeah.
Um,
Yeah.
she did an amazing job. Um, a couple of other people that I've just met that I've just been very good, but these have been the, the people I just mentioned have been my circle, and they've always kept it very, very real, no matter how bad that result is, and we can talk through any of those conversations. I also like the fact that, again, that we're bringing out lots and lots of products, and that we're
Yeah.
getting lots of products pushed and passed through the FDA clearance, because chronic disease, uh, chronic kidney disease is real, right? And I don't
It
know
needs
that we're fast
innovation.
enough. I don't think we're ready enough. Like, we need to move fast.
Yeah.
There was a lot of time that lapsed between when I first started in dialysis 20 something years ago to now, that we're
To
seeing a lot of
something significant
technology.
happening. Yeah, I agree with you. Like
Right,
it was kind of like the same song and
right,
dance for so many years, and all of a
right,
sudden
right,
we're struck with new drugs. We're struck with new
right,
devices that are coming out.
right, right,
Devices that are coming from across the ocean now, with things that have
right,
been around for a while, but just
right,
going back to reimbursement, we may still
right.
have to figure out some of that, but we're
Yes.
starting to have a bigger conversation, which is really
Yes,
important.
yes. So I
Yeah.
love it. We may not always agree with what who how, but we're having just the fact that we're having those conversations, I think, is making a world of difference.
Agreed.
And for every conversation that I disagree with, I always take something off, like, what was this person trying to say to me,
Hmm.
that I disagreed with? What was his perspective? And then, based off of that, can we problem solve for it, right? While still not forgetting that it is a business, right?
Yeah.
And
Yeah.
so, um, that's has always been the middle point of everything. So, with that said, I think we're doing a good job. Um, the nephrologists are doing a good job. Nurse practitioners are doing a good job. The techs, the nurses are doing a fabulous job. They're the ones that show up at 5 o'clock every morning. It's
Hmm.
not an easy job to do.
Yeah.
Sometimes three, four times a week. It takes a lot to take me out of bed at 5 a.m. in the morning, but they're doing it easily.
Yeah.
Um, and let's not also forget the patients. They're
Yeah.
the ones that are in the heart of this. And um, again, just going through being a patient, I think I was just as sick as my mom, honestly.
Yeah.
Going through the healthcare system as a patient, um, was very humbling. You're dealing with, and these are patients who have other comorbids, right? So, just even the plan of care while still trying to maintain a job,
Yeah.
should not be underrated. I just wish that we could do a better job with, and I'm just going to talk as a healthcare professional right now, that we could somehow do a better job with education, because I think that would really, really help the nephrology population with regards to prevention. And this is, I guess, this is where the VBC companies are coming in, and they're
Hmm.
trying to mitigate all of that risk. But there's still a lot of patients out there that still need the help. And this is 2025. We shouldn't be having patients sit on those dialysis machines if we can prevent it.
Agreed. I
Yeah.
gotta kind of finish with this. As you talk through everybody doing better, I'll agree with you that, even from the many hats that have to be worn today because of shortages, and you kind of talked about people not wanting to come in to the industry because of a lot of the administrative side of things. Well, that's part of the job these days, is to kind of cover like all those bases,
Yes.
right? But when you say education, um, there's a lot of avenues for that. There's the
Yes.
professional conferences. There's um, you know PSAs and marketing. But I gotta say, uh, I'm really proud of the patient advocates these days. The patient to patient advocates these days. They
Yes.
are coming out loud and strong with just the encyclopedia of experience and education behind them. There are groups that are advocating their patient advocacy, patient-led
Yes.
advocacy groups.
Yes.
Social media has become such an incredible tool. I know people that are patients, whether they have been transplant recipients, they have CKD4, they're on dialysis or peritoneal dialysis, that will reach more people than perhaps you and I ever will because of the
Yes.
followings that they have socially. And
Yes.
when you say
Yes.
education, I think, one of the things I'm looking forward to, just more evolution, is the way that we educate those champions so that they can go out and do the things that we can't do.
That is
Um,
correct.
you
Yes.
know, I'll go back to Latinos again, just because I know this very well. Is and I think it goes with a lot of cultures. Is
Yes.
I need to hear from somebody that looks like me
That is correct.
to be able to like make it hit home. And I know
Yes.
a lot of Latinos, they need to hear it in their language for it to be able to hit home. So you gave your shout outs. I want to give a few shout outs to some of those
Yes.
heroes today.
Yes.
Mark Coronel, the kidney fighter. I met this guy a little over a year ago, and he's become a brother. He's a living donor kidney recipient,
Yeah.
but he really is the kidney fighter. And he's out there, I mean, I want to say on the daily, doing something with somebody. He'll answer his phone, he'll reply on social media to people that just need some help in either keeping hope up or fighting, putting on the gloves and finding the tools to make it through
Yeah.
this. Uh,
Yes.
Justin Pham, who has also been a big advocate and somebody who's participated in the podcast many times, peritoneal dialysis patient. He just threw an art show on March 1st to kick off Kidney Month and really showed some vulnerable pictures of himself while he was doing peritoneal dialysis, all to raise awareness, to say keep yourself healthy, prevent it when you can. If you end
Yeah.
up in this possession, become educated and find the right fit for you. BD was the right choice for
Yes.
him,
Right.
and
Right.
then gave the public plea that he's looking for an organ donation.
Yeah.
Raised a lot of awareness about living donation, as well as the importance of registering as a kidney and tissue donor.
Right. Right.
And then most recently, a gentleman named Big Sleep. Some of you will know him from the art world. Just check our pages. He's put out a recent documentary, and perhaps
Yes.
one of the all I say is just very touching. Uh, it hit home hard, and I know that I sent you his documentary, but kind of growing up in a certain environment, to see somebody ask for help is a hard thing from that environment, and to
Yeah.
show the raw emotion publicly that he did and is doing, and to look for help and take an active role in finding his way, but in the process sharing with others, specifically with minority populations that are more prone to
Yeah.
things like type 2 diabetes and hypertension. Just again, these people are reaching more people than I will ever reach.
I have to
So
tell you that that documentary was very it was very raw,
yes,
and it was. I think it was also great to watch because um, you see that even the strongest of the strong
yeah.
um,
You see this
are still at risk of this
this
disease.
skateboard behind me, this deck.
Yes.
That's some of his artwork, a lettering master. But you're right. I mean, not what you'd expect, right? When as
Yes.
far as
Yes.
how vulnerable he allowed himself to be, not just for himself, but for others. So,
Yes.
that's what excites me right now, Lillian, is that people's voices are being heard. There's more dialogue to the conversation, more context, more color to the
Yeah.
conversation than there's ever been, from how to prevent, how to treat, to transplantation, to what complications we might not know about that we need to know more about, like the genetic
Yes.
testing and the
Yes.
predispositions that we had
Yes.
no idea about until very recently.
Yes.
So, we had a couple people chime in, uh, just to point out, technicians start at 2 a.m. sometimes.
Oh, I'm sorry. Wow.
uh,
We used to start at 4 a.m., so they rolled it back all the way to 2 a.m. Wow.
well, yeah, that's the openers, right? There's probably a couple
Yeah.
technicians that come in and get everything ready, and most clinics will start around 4:30 a.m. So tough for you, right? Tough for me. Also tough for those who got to show up to sustain life, right?
That is
Um,
correct.
but yeah, I just want to thank everybody who joined us tonight. I do see on the various channels quite a bit of dialogue. It seems like people have been engaged and have enjoyed the conversation with you, Lillian. And, I'm actually really looking forward to the day that we get to do this in studio. We'll do it in Bellflower whenever you come to Long
Yes,
Beach.
whenever I fly to California, I'm hoping that, I'm really looking to, as I transition mom back to dad, I'm looking to come back out, right, and join my colleagues. I really miss seeing all of them and hanging out with them and just having conversations. Um, so I'm
Well,
hoping to do that,
let's do
hopefully.
that before we go. You mentioned a lot of focus and time and hopefully the very soon to be reuniting of mom and dad in Maryland.
Yes.
What's next for you? Like what
What's
should we be
next?
looking out for, and what opportunities do we have to collaborate with you, whether it be with the musings or anybody online? We've got some administrators online, some technicians
Yes.
online, some students
Yes.
online. What's next?
Really anything. So, Dr. Way and I actually, Dr. Way, I and Tim, or Tim, I and Dr. Way, this English, all right, is we actually have a podcast that we try to put together, and we try to have conversations around policies,
Yeah.
around really the nephrology world, understanding the value-based care world, understanding products, understanding consoles, new consoles that are coming out, right?
Yep.
There's AI that is now predictive, that can help predict when a patient is at risk for CKD. These are things that we didn't have before. And so that's a platform for us to talk about. Personally, I've been just consulting recently. That's what has allowed me time to also take care of my mom. But as she transitions back, my goal is to definitely get back out and get back into the world of nephrology. I do love nephrology a lot. I think it's my heart and my passion and my soul. And when people see me and come in contact with me, they know it and they can feel it. Um, so what's in future? I'll say this: if you guys have something for me, I'm open. In the corporate world, it doesn't matter. In the clinical world, it doesn't matter. And I'm open at this point, and I'm open to seeing what is out there. Um, but I am ready to come back. I think that's the most important thing, and I am looking to do that in the best possible manner that I
Well,
can.
let me be selfish for kind of my perception on things, and I think a lot of the audience that we have and by the way, you are now part of the family, so you are now part of the
Thank you.
Musing with Morales family. And
Thank you.
when we talk about that network of high vibe people, I look forward to you meeting more of the family. And as you go through the podcast with Tim and Dr. Way, I would hope that if you have ever the desire to bring in some of these champion voices, that's not my voice,
Yes.
by the way. I'm just a moderator, but I would love to make some introductions of some people that could tell another side of it, because policy and regulation and reimbursement and technology is always very much needed. But I think a lot of the times, especially in the professional realm, like what we miss is like hearing a very subjective view
Yeah.
from patients themselves. And we happen to have ran across a lot of people on the podcast that are not the typical stories that you'll see
Yeah.
in dialysis centers or in nephrology centers, and can really offer a lot of words that would help to maintain hope, bring hope, show that there's a better way, show that, like, hey, what am I doing here in this center? Like I could be I could do this at home, or
At home, yes.
I could make a TikTok video and have increase my chances of finding a living donor by whatever fold that is. I've seen people do this, right? Who found their donors through social media, right? And got that second lease at life, right?
Look, been, I was, I think it was Oregon, and I was driving down the streets of Oregon on a highway, and I see people with huge banners. Um, and that never used to happen, but it's happening now, and I love
Yeah,
it,
yeah.
right? Because it could be anyone who could save your life. So I haven't seen that in New Jersey. That's interesting, but I did see it in Oregon that day, and
Mm-hmm,
I thought that
mm-hmm.
that was very cool. That was my first time of actually seeing it. But I'm starting to see more and more of people advertising it, not just on social media, but even on the high streets. The signage on the high streets.
Yeah,
Um, so it's good to see. Um, I think that, not apart from the fact that it makes people aware of being an organ donor or recipient, it also makes people aware of the disease and how serious
needs to
people
be
will
normalized to
go.
talk about it,
Yeah,
right? Yeah, it's not
right,
something that
exactly.
people. You go ask somebody, somebody in your family type 2 diabetic or high blood pressure, and everybody's hands go up. But when you start talking about kidney failure and
Correct.
dialysis, they're like, "What is that?" Oh yeah, my auntie, my uncle, and it's like all of a sudden like it's right there in front of their face. And I found
Yes.
also that once people get that exposure, all of a sudden it's all around them. You know what I mean? They never knew it. They never realized it
Yes.
before.
Yes.
And now once they sit down with somebody like you or me or one of the patient advocates that we've had on the podcast, like it's all in front of them all the time. They're like, I didn't even know that my boss, that my cousin, that my auntie, that my spouse had, these sort of things. It just becomes front and center.
Michael, I think that had to be part of the reason why we were in the basement, like 20 something years ago.
That's a
And we're
whole.
graduating to the first floor and second floor now.
You're right. Whole nother podcast, but I'll kind of share. I grew up with a dialysis patient. My uncle was on dialysis from the time I was born till I was 38. He did home
Wow.
dialysis. Originally, he started in a center, and he told me this story that it was in the basement and of a hospital, local hospital to me here, and the center was in the basement. They had coil dialyzers, and sometimes those dialyzers would, you know, blow up and blood would splatter on the roof and stuff like this. And there was a doctor trying to find out what he was going to specialize in. And he walked into the dialysis center and a coil dialyzer blew up in his face. And he said, "This is what I want to do," because of the I don't
The
know,
blow up.
the blow up. Yeah. But what was crazy is my uncle said, every day when I walked to or every other day when I would walk to dialysis, I walked past the morgue. And that's an eerie thought. That's why I said,
Very
when
eerie.
you say like it's in the basement, what else is in the basement in a hospital?
The mug.
Right. And if that's what you're walking by every day to this treatment that you've been told without it,
You be there.
this is a terminal illness, right? It's got to be a very daunting walk, a very heavy walk into the dialysis center. So hopefully
Yeah.
nobody else is in the basement of hospitals anymore, guys. But if you are, even more reason to carry the high hope, the
The
high energy
conversation. Yes.
for your patients.
Yes.
Yeah.
Yes.
But
Yes.
Lillian, I know it's super late for you there. Thank you so much for taking the time to
Thank you for
join us.
having
Look
me.
forward to the next one. And
Awesome.
everybody who joined us for spending some time with us, hopefully you learned a lot. Lillian, is there any way that, I mean, I don't know if I know you have LinkedIn.
I do have you.
So is it okay if we have some folks that, may want to connect with you, kind of learn more about you, that they reach out through
Absolutely.
LinkedIn? All right. So
Absolutely. You can reach out to LinkedIn. I do have an email address, but I think that's also on LinkedIn as well.
yeah,
So
be in the
yes, you can reach
contact
out to me
profile.
there.
Yep.
Yes. Yeah.
Yep. Well, everyone, it's been a great evening with you. Musings with Morales, Lillian Ok- Okonkwo.
Okonkwo.
Okonkwo. I'm going to get it on the third one. Um, it's been such a pleasure, and love the smiles and the laughter. And by the way, I meant to say this in the beginning, but ever since we started talking, Guys, isn't it everything that she says sound really, really good? I mean, your enunciation is,
Really?
yes, like
Because
when I
I'll
hear
tell
you
you
talk, it
something. I
makes me
think
want
I've
to
just
listen.
gotten. I think I've just gotten old, and I've given up on the fact that I want to change the accent.
No,
So
don't change
it's
it.
what it
It's
is.
great. Uh, I, I'm a fan.
Oh, thank you, thank
All
you.
right, everyone. Have a great
All
night
right,
and talk to you
you
next time.
too.
Bye bye.
Take care.